around 55% of them are non-road traffic injuries, which involve fall from heights, animal attacks, and other things, and farmyard accidents. It just gives us a food of thought that how much burden of injury, how much burden on economy trauma serves us. So I would not say that it's a hype which has been generated by trauma. I'd rather say it's a realization that the world is coming to. A realization is a gradual or sudden understanding or comprehension of something that was previously only imagined. We knew that something was happening, but this social media and data-driven society has come to a realization that trauma is something which we need to work upon. Trauma is one of the biggest killers of humankind. It cannot be done until and unless we consider trauma as a disease. Star diseases like HIV, dengue, and all things have been taken, and rightly so. They had been taken importance, but trauma has always been ignored. It has been considered as an act of God. But trauma is just like any other disease, with the epidemiological triad of agent, host, and environment occurring in trauma as well. It is a disease with variants. It is not an accident, but a disease with degrees of severity. It is not an accident, but a disease with rates like any other disease. It's not an accident, but it is a predictable pattern disease. And last or not, it also has a predictable prognosis like any other disease. So it is now that trauma is getting the importance and the stature of a disease, and the country has is realizing it, and it is very good for the humankind that it is. Such realization happened to us at AIIMS Rishikesh also. So how did we deal with this hype? I was talking to Dr. Shefali, who's in charge of trauma surgery here, and she said, you know, the story of trauma should be said, that why is this hype, or how should we deal about it? So all I can tell today is my personal story, which might give some answers. To us it did. Hopefully we could convey some things to you. Before 2019, by the mentorship of my faculty at AIIMS Delhi in JPNATC, we developed a level 1 trauma center in AIIMS Rishikesh through my thesis, which was a capacity building program to develop a level 1 trauma center. We implemented the WHO Essential Trauma Services guidelines there, infrastructure, manpower, process and protocols. Over the period of 3 years, we trained 50 doctors and 50 nurses for trauma care, and we also trained the nurses for it. And we started a level 1 trauma center in 2019. But we had a realization. After working in our center for 6 months, we realized that we were not getting non-responders. We were not getting patients who need a trauma center. We are getting patients of fractures, we are getting patients of other things, but patients who actually need a level 1 trauma center, we are far from that. Though, when I was doing my residency in AIIMS Delhi, we used to get such type of patients each and every day. So we looked up the data we were working about. We realized that there was an accident, bus fell into a gorge in Uttarkashi. 29 people died on the spot, 2 reached AIIMS Rishikesh. School bus fell into a gorge in Tehri. This is just the 6 months data, multiple casualty events presented to AIIMS. 17 died on the spot, 4 reached AIIMS Rishikesh. Chinnalisauda bus accident happened, 23 people died on the spot, 6 reached AIIMS Rishikesh. And bus fell into a gorge into Neelkant, 12 died on the spot, 7 reached AIIMS Rishikesh. So we calculated the injury severity score of all these patients, and we realized that the injury severity score was not that high. I mean, these patients could have been taken care in CHCs and PHCs. They didn't need a trauma center AIIMS for this. And then we condensed into that we are not getting live patients to the hospital. That is the problem. So we need to have live patients. Only then we can make a difference. Only then there was a relevance of a level 1 trauma center in the state. So what do? We don't need to reinvent the wheel. The world has done already a lot. We went into the literature and realized that this problem has to be dealt with in the form of inclusive trauma system, where pre-hospital, in-hospital rehabilitation, policy advocacy goes hand in hand. And I want to show how we dealt with it. So global goals, local solutions. AIIMS Delhi had provided us with enough ammunition to start working. We also went to Rambam, Israel, to see their services, how they save time. On a fellowship was sent by AIIMS Delhi to Osaka City University Hospital, Japan, where I deeply learned and was very impressed by their Dr. Heli systems. We went to the first trauma center in the world, that is Shock Trauma Center, Maryland. And we partnered with them on collaboration academics, and also went to the Kernan Rehabilitation Center, which is one of the best centers in the world for rehabilitations. We also went to third world countries like us, which despite of their, meager economy were doing very good in trauma services, pre-hospital care. And then we took along senior bureaucrat from the state and director level health officer from the state, and together as a team of 3, we went there to go and see the trauma systems and implement some of them back to our state of Uttarakhand. These are some of our collaborations we did. We realized that pre-hospital care will have to chip in, though it is not a mandate of a hospital or a AIIMS Rishikesh for that, but if we want to be relevant, we need live people. We realized there were problems in pre-hospital care in the state. There was no single universal access number. There were silos. Administration was working separately, fire was not talking to administration, police was separate, healthcare was not talking to anybody of all. So patient was suffering in them. We also realized there is no first responder cadre in the state. Like we have paramedics in West, we had nobody. So only thing we were looking up for was police. Sometimes would carry these patients to the hospital. SDRF personnel who after 2013 incident came into being and started helping us. And sometimes the taxi drivers of Char Dham Yatras and all, they were the first responders. And we also realized that 108 has been working in the state, but there was never a clinical audit of 108 and it was not working as it should. So what to do? First thing is we clear up our home. That is what we realized before making a change. So we realized that even our hospital and even in the department, if you wanted to call for one problem of one problem for a trauma patient, you will have several numbers to dial. So we started trauma telemedicine in October 2022. Every year on World Trauma Day, we start one new thing in our center. We started that, and I'm very happy to say that we have done more than 48,000 trauma teleconsultations, and 10% of them are life and limb saving. So if anybody has an injury to the finger while cutting vegetables at home, they can call at this number. They will be given advice, evidence-based advice, that whether they should get a TT injection, how to do. If somebody gets a severed finger, they will be given an advice. A bed will be made for them in AIIMS Rishikesh. The OT team will be informed that a time-sensitive patient is coming. The residents of trauma will be outside on the door to receive this patient and receive his finger. So that is trauma telemedicine in our state. We got all the stakeholders under one roof. We invited SDRF, we invited police, we invited local administration. We got all of them, and then we started doing mega drill. So now we have a 1-week World Trauma Week in our state, and in this we get an accident of 2 buses, a pseudo accident of 2 buses, and more than 100 patients are involved. And with help of all these people, we tell SDRF how to evacuate the patients, taking care of their primary survey and secondary survey. We bring the doctors who are stakeholders of trauma in the state, in the government setup, and let them see that 100 patients can be managed in one single hospital. So if resource is not a problem, the mindset and the protocols are. Then we started training police. We started this before COVID, then we integrated the COVID training along with this setting. And then we also started training the taxi drivers and all for this. We are also presently officially the trainers of SDRF, and we're revising the manual as well. ITBP is one of the stakeholders in the peripheral areas in the state, the border areas. So we also train those people. And we also realize that if we have to do training, it should be the young section of the society which have years of life left. So if you train elderly, we are probably just dyeing the end of the hair. So we wanted to dye the end of the roots of the hair, so we started school awareness programs. And I feel very proud to say that every year we are training 5,000 students around Rishikesh for this, for trauma first aid. I also want to proudly say that there's a catch here. We don't train different people for 5,000 years. We train the same students for 3 consecutive years. So they're trained when they're in 7th, they're trained when they're in 8th, they're trained when they're in 9th. So when we go on the 3rd year, our history of just for 5 years now, so when we reach them on the 3rd year, half of them they already know, "Arey sir, ye to log roll aise karna tha." You know, spine stabilization, we can already do it. So they're not just sensitized individual after 3 months, they're actually providers. And one provider in a family means a lot. So these are some glimpses which we do with the help of our our trained nurses, and I'd like to specially mention to Professor Subodh sir, we have the highest number of ATCN trained people in the country right now. So this team helps us to do all of these, the nursing train. Recently, the civil servant, the institute approached us and they wanted to integrate the civil servant training. We had been doing a lot of work with the state. They realized the potential. They realized that we should speak the same language. And if all the stakeholders learn the safe language, then definitely it matters. So we now regularly train them in Mussoorie, Labasana for trauma training as well. Coming to pre-hospital care, the patient transport, we realized that 108 ambulance was clinically never audited. And when after 3 years, the time to increase their salary was there, they were shunted off, new patients were taken because of the L1 thing. And whatever they learned from hit and trial, that was also gone. So we'd seen this in AIIMS Rishikesh, people bringing polytrauma in a wheelchair. Our hearts slept into our mouths. So we advocated clinical audit for those patients, which state has agreed. From this year, it will be started. We also realized that the future was HEMS. Uttarakhand has a geography. For example, somebody gets a head injury in Kedarnath, so he cannot be operated before Dehradun or Rishikesh. A neurosurgery wouldn't be possible. And to reach there is approximately 8 hours in the cold times, and when there is Char Dham Yatra season, which is almost every 6 months in a year, it is almost impossible to reach hospital within 12 hours. So it is a death sentence for these patients. We're all doctors, we realize that. But if you see the aerial distance, it's very less. Within 45 minutes, patients can comfortably be evacuated and brought to AIIMS Rishikesh if a heli service is there. More or less, it is not coming to AIIMS Rishikesh that gets its treatment started. Our team can go to that place and start the relevant medications, mannitol and all those things, so that the patient does not suffer and patient head injuries or injuries are mitigated. So we worked upon this direction. We did a successful trial of air ambulance at AIIMS Rishikesh, and we got the first center in the country to develop these services. This is our team at AIIMS Rishikesh. This is the Honorable Director. So we designed the helipad, we took all the relevant permissions, we all developed processes, protocols, and systems, not just for AIIMS Rishikesh, but for now it's standard for entire country. We trained the manpower for this. There was no course for it, so we reached other countries where the courses are there. We started courses with them, and now AIIMS Rishikesh is coming with its own aeromedical course for this. This photo is very dear to my heart. My son is there in the audience. It is him when he was very small, the left topmost photograph. This time the helipad was being made. So I took him from home. I said, let's go there, and I want to take you there. And you will have this memory for the rest of his life. I made him put his foot there. So that impression has been covered, but now also he realizes when things happen that, okay, fine. So we were a part of something which was very great. And now we have a very good working heli services in AIIMS Rishikesh, first in the country. And then there are many successes, not just for trauma, then it became for all the emergency services, time-sensitive, stroke, cardiac arrest, gynecological problems, and all those things. So till date, we have airlifted 308 patients from there. Our average airlifting time, that is to start the process, and start of the time is less than 30 minutes. And estimated average time when you calculate patients coming to AIIMS Rishikesh from different parts is 8.5 hours. So you can understand the changes it might have gone. So now coming to the in-hospital trauma care, which is our core competence and which we thought would develop. So with help of my training and my guidance from faculty from AIIMS Delhi, we established a state-of-art trauma state-of-art of trauma emergency, which is boasts of 21 beds, and every bed is ventilator ready, and every bed has a ventilator, though green areas seldom do, but green, red, yellow, whatever area we say, they're all ventilator ready. We have 21 beds, centralized oxygen supply in each bed and everything. We also started state-of-art trauma ICU. So presently we have 14-bedded trauma ICU, 12 beds with 2 isolations, which we have recently started. So I'm very proud to say and that because of my training in AIIMS Delhi, when we started it, we were supposed to find beds in CCU because you cannot have a patient without an ICU bed. So it was very difficult to procure bed for them. And we were regretting cases day in and day out because of non-availability of beds in CCU. So we started with 2 beds, then gradually went to 6 beds, and now fully fledged 14-bedded ICUs we have, only being managed by trauma surgeons. No, not a single faculty of anesthesia, not a single faculty of critical care, managed only by trauma surgeons. Obviously, parallelly, we developed the nursing capacity for it, and now we are into categorizing them as respiratory therapists, bed sore nurses, trauma nurses, and so on and so forth. So presently, our department has 5 faculty, permanent faculty. Other faculty are on rotations. We have 10 MCH senior residents right now. So, I mean, this is, I think, an old data, because now we have much more. So I'll probably show it in another slide. We started thoracic surgery program as well. And with the help of mentorship of AIIMS Delhi, we started a thoracic surgery program in there. And now we started, after this surgery, with my faculty, Dr. Bipla Mishra from AIIMS Delhi. And we are doing almost all the decortications of AIIMS Rishikesh, all the benign aspergillomas and VATs we are doing there in AIIMS Rishikesh. We also started non-trauma surgeries by trauma surgeons, but then we are very ably helped with the neurosurgery department. This is me performing the first non-neurosurgery head trauma in AIIMS Rishikesh by trauma surgeons only. And then our focus went to the third wing, that is rehabilitation. We started an amputation clinic we were doing in AIIMS Delhi, physical rehabilitation and social rehabilitation. So presently we're working on the social rehabilitation part, that we believe that somebody who's met with an accident should be a productive member of the society. If some guard loses his limb and he has no education, he becomes a burden on his family and society. But to integrate them in a system that he is a productive member of the society, we're working with NGOs now. We have had several success stories. We had this patient. Actually, when we started the World Trauma Week, we started with the cyclothon. Wonderful pictures came into press, but we thought that we were not going anywhere. So we needed to do something substantial. So we started the concept of trauma rath. A rath which starts from AIIMS Rishikesh, goes to every government medical college for training. More than training, we realized what we developed was a network. People knew what AIIMS was doing. They knew they had a number whom to call to. We knew who was calling to us, and patients started pouring in. So I want to bring your attention to this space. In a construction site, his hand was severed. And then he came to us, and this is his post-op thing. This was the first hand reimplantation in AIIMS Rishikesh. In entire Uttarakhand, I should say, at the shoulder level, with perfectly working, all done by trauma team. Then this, we always get, all the trauma surgeons are very happy to get this, that the rod, it passes through the patient. This was somebody who was driving a car, fell down a bridge, and below there were construction rods coming out of the sides, went through, along in the car, through his chest. After 7 days, went home walking after doing torsotracheotomy. And then obviously cardiac trauma, which is a very good thing for us. We started, till date we have done 9 such open trauma surgeries in AIIMS Rishikesh. Out of them, 8 have survived. Amazing data, I must say. And then we wanted to pitch into policy and advocacy. We started multiple collaborations with our state government. We started the Vaibhav program with the Champion Center for the Vaibhav, the Prime Minister's program, Vaishvik Bharat Vaigyanik Summit. And we are working together for a EMTALA sort of law, which started revolution in USA in 1980s, and that would grow. So these are all the 4 wings of our strategy: pre-hospital, in-hospital rehabilitation, and policy advocacy we took. These are some of our collaborations we did. We recently collaborated with Alimco, that is Pradhan Mantri's artificial limb organization, which gives subsidy for anybody less than 30,000 rupees per month gets a limb for free, and these are state-of-art limbs. These are not just a regular Jaipur food. This is the latest. So end of last year, we got this thing from state. It was SRHC was starting its first in state resource health center started. So we convinced them to get trauma as the first project. So now we are in a process of developing an inclusive trauma system in the state. Lessons learned is public-centric approach matters rather than institute or department-centric. When we become department-centric or institute-centric, we become enemies. But when we become patient-centric, all of us become friends. A personalized approach, I realized that we should have numbers of anybody who want to call. That is one of the biggest realization I had. A file will never reach and make a difference unless you call somebody. So you should know the person who is supposed to do the work. You should give it a call. And nihilism, that nothing happens in, especially the government sector, I think, is actually a myth. So this is the newest. That was from my last presentation, probably a few months ago. We have five permanent faculty. We have an MCH in trauma surgery and critical care. 9 MCH residents presently we are having. We started sports injury also, which is being very well taken care by. MCH 7 residents in sports injury we have, and PDCC spine we have 3 residents. And apart from that, residents from all other specialties like surgery, CTVS, emergency medicine, they come to us for rotations. And we are running all the trauma courses which are present in the country in our institute. So, why the spotlight now? I think spotlight is also because of the lifestyle, which I failed to mention earlier, I intentionally did not. If you see Grey's Anatomy, it is all about trauma. If somebody who after his MBBS decides to go into surgery, he is definitely going for trauma. That is what he dreamt of. He is not going there for a gallbladder removal. So it's a hardcore surgeon's pleasure. Initially, there was no scope in it, but with the advent of trauma surgery as a specialty pioneered by AIIMS Delhi, people have realized that now there's scope for it. Trauma centers are coming everywhere. Country has realized the Department of Trauma and Burns has been investing heavily. This year, we have a huge amount of money for trauma care, this thing. And obviously, there are rising incidences of trauma cases, accidents and violences. You know, one more round and all those things, they make a huge impact on social media. And when these patients are saved, it's a celebration. Advances in technology, microsurgery is not that microsurgery which used to be done before. Implantations, probably even in my time as a residency, were big things. Now they're being done everywhere. So outcomes are improving. Technology is improving. Media and public awareness is already there. And most of all, the patient outcome gets better. The trauma surgeon takes ownership of the patient. The patient is not football between orthopedics, trauma, and other departments. And he only takes help when multidisciplinary, obviously it's always a teamwork, multidisciplinary care is always needed. But the ownership is there and the outcomes are better because it's not just about anatomy, it's about physiology as well. Thank you very much for giving me your time. I'd be happy to take any questions, please. Thank you.
Yes, sir. Anybody wants to ask any question or comments to Dr. Madhur? Dr. Madhur, I'll just say a few words, though it's a wonderful presentation. And I agree with you, it's not the hype, it's the realization. We have to realize trauma is a big problem in our country, as you very rightly said. It's a problem of the young people. And around 1.7 lakh people die every year in our country because of trauma-related injuries. 50% of which are road traffic accidents, which is a major problem. And being in Sharda Hospital, we are close to 3 main highways. Yamuna Expressway, and some more highways are coming up, more and more highways coming up. So trauma is maybe, I don't know whether going to increase or not. But one of the main bottleneck I feel we face in our country is not adequate training of the doctors about trauma. Most of the medical college do not have a trauma course or MS in trauma surgery is not there. There is MS general surgery, MS orthopedic surgery, or MCH neurosurgery, MCH plastic surgery. So whenever we get a case with a polytrauma following a major accident, almost all the systems are involved. Nobody is willing to own up the patients. Everybody says it's not my case, it's a primary neurosurgery case, neurosurgeon it's an orthopedic case, orthopedic surgeon said it's a general surgery case. So I don't know who takes over the patient. That is the one major problem we face. And that's why time is lost. Initial crucial time is lost. And then sometimes we are not able to save the trauma patients. Pre-hospital, you have taken wonderful steps in improving pre-hospital trauma care in the state of Uttarakhand so that trauma patient can reach within golden hours. Another thing, the flagship course of trauma training in the India ATLS course. More and more doctors should come forward and do the ATLS course, started by Professor M.C. Mishra and taking lead by the AIIMS training faculty. I was surprised when we started the ATLS course in our institute. Not many PGs are coming forward to register for the ATLS course. I feel as NMC has made a mandatory ACLS course for all the PG students before their MD or MS examination. They have to undergo ACLS course. So they all come forward willingly to do the ACLS course, 3-day ACLS course. But ATLS is not mandatory as per NMC. So I feel NMC should take a step forward and make ATLS mandatory. Then only the young doctors, the PG students will come forward to do the ATLS course. And I'm sure within 3 days course, they will learn good amount of life-saving skills. And wonderful to know that you said trauma ICU. I've not seen trauma ICU in many of the hospitals. And that's wonderful talk overall from my side.
Thank you, sir. Thank you very much.
Thank you, Doctor. Thank you, Doctor.
A thunder round of applause for Dr. Unial, please. A thunder round of applause. Dr. Unial, your unparalleled expertise, precision, courage, and unwavering focus in critical moments make you an invaluable asset to the community. I would now request our esteemed Chairman and Head Internal Medicine, Dr. N.K. Soni, sir, to kindly come forward for the felicitation. A huge round of applause, please.
Hi, good morning, everyone. I'm sorry we will take a little 5 minutes break since our Honorable Health Minister of Uttar Pradesh has been very kind to accept our invitation to come to the conference. There is a small security check. Please bear with us for 5-10 minutes. We will continue soon. Thank you.
moving on to our second session of the morning with code trauma, the missing link in emergency care. To deliver this important talk, we have Dr. Shefali Chandra, trauma surgeon at Yatharth Hospital, Greater Noida. A big round of applause, Dr. Shefali Chandra. Dr. Shefali Chandra is a certified trauma surgeon trained at AIIMS under leading experts. She specializes in comprehensive trauma management from non-operative to emergent damage control surgeries and excels in emergency surgery and interdisciplinary teamwork. Known for her quick decision-making and leadership, she is dedicated to improving trauma care in India. This session will be chaired by Dr. Nalini Bala Pandey, Head Emergency Medicine, LNJP Hospital and Chief Medical Officer, NFSG. Dr. Nikhil Gupta, Consultant Orthopedics, Yatharth Hospital, Jhansi. Dr. Prankul Singhal, Consultant Neurosurgery, Yatharth Hospital, Noida. Dr. Farah Imam, Head of Emergency, Yatharth Hospital, Greater Noida. I'm requesting the panel, please come on stage to join Dr. Shefali Chandra. Dr. Shefali, stage is yours.
Thank you for such a kind introduction. A very warm good morning to all of you. I am super thrilled to be here among you all talking about a topic which is very, very close to my heart. So I am a practicing trauma surgeon in Yatharth Hospital, Greater Noida. And I happen to be fortunate enough to be trained at the Apex Trauma Center, that is AIIMS, New Delhi, as a trauma surgeon under the esteemed pioneers of trauma care. When I was working in trauma center, I thought life is simple, A patient comes crashing, everybody knows what to do. You will find the patient in OR in 5 minutes. You operate, most of the times you have a happy ending. I was naive when I stepped out of trauma center. I joined Yatharth. The management was kind enough to give me this opportunity. And I noticed a stark difference. Patient is the same. Injuries are the same. The patient is still crashing. But we actually have to coordinate with at least 10 people to take that crashing patient into the OR immediately. Then I thought, let's do something about it. So, a lot of you are emergency physicians here. Ask yourself, this patient comes into your ER. What do you think will be the door to OR time? Ask yourself honestly. What do you think? Half hour? 1 hour? In AIIMS Trauma Center and in Yatharth Hospital now, I can say this patient was shifted to OR in 12 minutes after complete evaluation in 12 minutes. This is the power of a predefined code, the change it can bring about. Let me see a show of hands. How many of you have a code FAST, code STEMI in your hospitals? Please, come on. Yeah, don't tell. Every hospital has it, right? So many hands. They all have their sirens, right? How many of your hospitals has a code trauma, a documented, defined code trauma? And okay, so half of the hands are Yatharth, they don't count. Yeah, no, I'm actually happy to see some hands here, right? But even now, this is a big problem. We understand the importance of time in stroke, sepsis, but trauma still waits for someone to notice. Minutes bleed into mortality, but where is the code? Trauma is the only true time-critical multi-system emergency without a code. Imagine we are racing against time for a clot in the heart, in the brain, but what about the bleeding patient in front of you, which is involving all organs? We have designed these beautiful, beautiful systems, beautiful codes for different organs. But what about a shattered chest, a pulseless leg, a really mangled patient who has come to you and is gasping between life and death? Doesn't that person deserve a code? Doesn't that person deserve all of our attention? I do not need to stress on this reality any more than Dr. Madhu Runyal already has. Trauma is a problem, and believe me, this epidemic is only starting. We are not even at the peak of it. It is going to rise a lot before it starts to fall. We need to prepare ourselves, or we are going to lose a lot of young lives more and more every day. And let this fact sink in that it is actually the leading cause of death in the younger population. Imagine the productive population of our country are just dying left and right in accidents. They are not sick, they didn't have a heart attack, they didn't have some disease, they're just dying because they had an accident. It's frustrating, isn't it, that a person just bled to death? So do you really feel, why can't we attend a trauma patient after 3-4 hours? Let me finish my rounds. Let me complete my notes, do my PAC. Then let's attend the patient? No, because it is documented, it is proven. Timely intervention within the golden hour reduces mortality by 30 to 40%. That is a remarkable number, remarkable number. In trauma, time is not an issue, time is life, period. We are running against the clock in trauma. But here's an idea. So I'm not saying that we all can replicate AIIMS Trauma Center. That is something exceptional, something which the stalwarts of trauma have worked for years to perfect. But in our corporate hospital especially, we are all dealing with multiple specialities. It is not possible that everybody just leaves everything to come and attend trauma. But what if it had a panic button just for those critical patients who have minutes to live? What if it had a panic button? You press that button and a predefined, unified response is initiated. What we want to do is we want to take chaos to control. We don't want the research team to scramble. We don't want that the CT room is unavailable, the OR is unavailable, the specialties are not aware that the patient has come. There is one alarm and everybody knows their job, what to do. Yatharth formally launched Code Trauma in February 2024, and since then we have seen a remarkable reduction in our door to OR time, a remarkable reduction, therefore, in the mortality of patients. In the polytrauma panel that we discuss soon after, which Dr. Parul will be leading, you will see that the patients you might think will not survive cannot walk back home. They went back home, not because we did something different. We did what protocol says, but we did everything faster, in a smoother way, like a well-oiled machine. So Yatharth has not just done it in a verbal form, we have actually formulated a code trauma in conjunction with all of the multiple specialities that also includes the blood bank and the radiology team, and we have actually formalized it, got it signed by our management, and it's been over a year and it is running successfully in our hospital. Now, the concept is simple. I have repeated it already multiple times. The idea behind code trauma is no patient should bleed to death in ER. Simple. We all know hemorrhage is the #1 killer, but if you don't identify it timely, how will you stop it? And where can the patient bleed? Very simple. There's only so many places the patient can bleed in trauma, 1 on the floor and 4 more, right? So we need a system which can identify these sources of bleeding. We need the X-ray to come immediately so that we can rule out intrathoracic pelvic bleeding. We need a USG fast ASAP so we can rule out intra-abdominal bleeding, even intrathoracic bleeding. We need X-rays to rule out blood loss in the extremity bones. So we need all of this to happen, this code trauma to happen, so that everyone comes together, we are able to find out the source of bleeding, stop the tap, replace blood volume, save the patient, go home happy. Now, how to go about it? I cannot do it alone. A trauma surgeon cannot do it alone. Nobody can do it alone. Trauma is one discipline which needs all of these specialties to work together. Let's start with the ER. Our ER is doing an amazing job under the guidance of Dr. Farah Imam, who's sitting here on the panel. She's the head of emergency. The resuscitation that I have seen in the last 1.5 hours in Yatharth ER, it makes me emotional. It makes me so happy. It's state-of-the-art resuscitation. So the role of ER team in code trauma is to quickly identify a crashing patient, quickly identify a non-responder as we name it, start resuscitation and alert the code, right? The role of radiology is the radiologist for bedside ultrasounds on call comes immediately. Nobody has to call him. He hears the code on the speakers, arrives immediately, does the USG fast there and then. The radiographer comes with the bedside X-ray machine, shoots the X-ray. Nobody has to tell him, you shoot this X-ray, you shoot that X-ray. No. Chest pelvis X-ray is a standard. If any extra X-rays we need, we do tell them. Right? ICU team hears the speaker announcement and is ready to receive the patient. Blood bank, I tell you, Dr. Supriya is sitting here. She is the head of blood bank. And I think Dr. Subodh is sitting here. Sir, I dare say, we get blood faster than AIIMS Trauma Center. I can dare say this. So blood bank technicians literally run. They literally run with 2 packs of 1:1:1 blood and stay there with us till we ask them to leave. And if we need more blood, another technician will come running. He's not going to go back. We save time, seconds at every step. The blood bank is doing an amazing job. And it can be done everywhere. OR is kept on standby when the code is announced. Anyhow, they will either stop, if possible, they will stop the case or they will delay the next case. Right? Security is informed and a lift is held till we cancel the code. And obviously multiple specialities. So in our hospital, me being the trauma surgeon, I am a part of ER team. I stay in the ER, but also the orthopedicians, neurosurgeon, and other specialties, if required, are informed to come and visit the hospital, visit the ER ASAP. Now, when to initiate? See, this protocol can differentiate based on institutions. You have the freedom to create your own code trauma. In our hospital, we follow this. If a patient is a non-responder, that is a systolic BP of less than 90 after 1 liter of crystalloids, and an obviously exsanguinating patient in extremities requiring life or limb-saving surgery. Who can initiate? Practically anyone can. Who has seen the patient in ER, has resuscitated the patient. In our hospital, usually it's the ER physician, the trauma surgeon, or the nursing TL. So I'll show you a video. This is a simulation, but I'll also show you a real picture later, which is not as beautiful, so I've kept it for later. I'll show a video of how actually code trauma runs in our hospital. Code has been announced on the speaker. I think the audio is missing here. TL is at the caudal end. There is the airway doctor, the other doctor. X-ray machine has come. This actually happens. We told him to act in this, but this actually happens. That's the radiologist doing the fast. This is our beautiful emergency team. After a lot of hurdles and practices, mock drills, we have perfected this code now. And I'm actually very proud of it. Very, very proud of it. So much so, we have incorporated code trauma, you can see at the bottom, into our safety codes. These printouts have been actually changed now. It is not an NABH requirement, mind you, but we still did it. Code trauma is a part of Yatharth now. What do we want to do going forward? We want to continue doing regular mock drills. We want to include this code in resident and nursing orientation. And we want to discuss the outcomes with them, which we do informally with the ER team. We have kept feedback forms, but we would like to work on them more diligently. And we want to really drill into the brains of everyone in our hospital at least. Code trauma is as important as code STEMI or code FAST. So yeah, this has been emphasized so much since morning in trauma. Time is life. Time lost is life lost. Let's become the team that wastes neither. Let's make code trauma the new normal. This is the actual photo I'm talking about. I did not put it first because universal precautions is a bit of a problem in this photo, but I was the TL here. I'm standing at the leg end, and it just struck me that, wow, this team is doing such an amazing job. The radiology, you can actually see the suprapubic view of FAST in the ultrasound machine. You can see the X-ray guy is doing his job. Nobody is telling him what to do. Airway has already been settled in this patient. One person is on IV, one person is applying the splints. Everything is being done together. No chaos, no confusion. Everyone knows their job. So, which is giving us better outcomes. So in the end, I only want to tell you, keep calm, call the code. Thank you very much. I am open to questions.
Congratulations, Dr. Shefali, for the great speech. Anyone in the audience wants to take up the questions, please?
Mike.
Hello. So I just want to comment upon when you said that you are worried about universal precautions. So they say in trauma, antisepsis is luxury.
True that, sir.
It is not a necessity. That's why, unlike the 10 minutes hand washing rule and everything does not apply, we can control sepsis later, but not on the cost of bleeding.
True.
Of course, it is required, it should be respected, but first we need to stop the bleed. Thank you.
Actually, after clicking that photo, I have now hung gowns in the ER everywhere, me and Farah ma'am. So they remember to wear those when a patient comes now. So hopefully. Sir, please. Mic is not working. Mic.
Shefali, excellent presentation, an excellent talk, and you deserve all the praise. And I request to give him a big round of applause.
Thank you, sir.
It's very easy to do things in like our centers like AIMS, but single-handedly in a corporate sector to make a change, it really requires a lot of courage, support, and you have shown that yes, if there is a will, there is a way. And in the lighter vein, I will say that Guru good reh gaya, chela chini ho gaya. So it's wonderful, and I can only say that it's a very, 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 very proud moment for all of us.
Thank you, sir.
And seeing you growing and taking care of the trauma patients, and you have realized, and because you are a trauma surgeon, and I'm sure that your core trauma will spread across the country, and more hospitals will adopt this. Congratulations once again.
Thank you so much, sir. Thank you.
So I'd like to say that it has been a pleasure, the journey of court trauma and working along with Dr. Shefali. And believe me, it fills my heart with happiness when we come across this patient who had come to us just on the brink of death. And he comes, and now after recovery, he's come, a tracheostomy side pe, can I have a tattoo made? So it was amazing, and this patient would not have survived in a, I can claim that it would not have survived in any other emergency, in any private hospital, in NCR, the way he had come. So I'm like, it's a challenge for people to come on board and start court trauma as we are doing, maybe with modification as per the requirement of their hospitals to save lives. So that's
Thank you,
amazing.
ma'am.
She's turned it around for
Dr.
us.
Shefali, wonderful talk, and my compliments to you. You gave a wonderful concept of court trauma. I think we'll also think of starting court trauma, the need, definite need. There's one question I wanted to ask. You said that blood arrives within few minutes for the trauma patient. What type of blood do you give? Is it typed and cross-matched? Or like nowadays what I find the popular getting low titer O positive blood is very getting popular for trauma patient, for pre-hospital trauma care. So is it a typed cross-matched blood you got within 10-15 minutes? Is it possible?
I was actually expecting this question, sir. So we give O negative blood. O negative blood. So our major hemorrhage protocol goes like, we get 2 packs, 1:1:1 ratio in the first go, right? That is O negative blood, but the blood bank technician there itself, bedside, does blood grouping. That is done within a minute only. That is also a commendable job. I think I will let Dr. Supriya explain this, yeah. Please. She's raising her hand.
Hello, sir. Yes, sir. So
She's the head of blood bank in Yatharth. She's the superstar of court trauma here.
Sir, we have inventory of O negative, other unit also inventory of type and screen of all blood. But in case of emergency, we have to issue within the 5 minutes. So we will go for 1:1:1 ratio of O negative, PRBC, FFP and platelet. But all blood in the inventory is type and screen. Not cross-match, type and screen. Because type and screen is now according to the guideline, we have to do this. But in our central, we have one protocol like bedside rapid blood grouping. So we can prevent our O negative blood group. It's a part of patient blood management also. I think so. Most of institutes are not following this. They issue O negative blood in first pack. But yes, we issue O negative blood with bedside blood grouping. So
And
we
it's
save
quite
our O
fast.
negative blood.
And this blood grouping is like immediate. Within a minute, they'll do it bedside, and that set of blood they'll issue next.
Yes,
And if not, they will issue O negative. But blood doesn't stop. Take it from me, I have troubled them a lot.
Yes,
blood
we
blood
issue-
comes.
Yes, we issue O negative along with rapid blood grouping. And all blood unit has a type and screen done in our inventory. So this is all. Thank you.
At the last, congratulations, Dr. Shefali and Dr. Farah and whole of the team Yatharth for bringing this code actually live and practice. And that 12 minutes is like super excellent for this. And being like heading from the government sector, Loknayak Hospital, I know these has to be incorporated in our hospital, and this is a vision exactly. And I promise that now onwards, like this is going to be from day one, I promise it has to be established in our hospital as well, and whole of the government sectors of Delhi. You are like visionaries for all of us, and we incorporate, and we might need your help in our sector to grow this code.
I'm
We'll call
very
you for
happy to
that.
hear this, ma'am.
Best
Very
wishes,
happy.
and this is great.
Thank you, ma'am.
Best
Thank you.
Congratulations, Dr. Shefali, for this wonderful presentation. So hearing you, I mean, I passed out my neurosurgery from PJ Chandigarh almost a decade ago. So over there, we didn't have a separate trauma team, I think, like the AIMS has. So most of the polytrauma cases or whatsoever, they used to be manned and managed by neurosurgery department over there. So two consultants of neurosurgery and residents of neurosurgery were always posted in trauma department, and this takes me back hearing you guys talk about all this, because every single morning after doing all the night surgeries and cases, we were supposed to present the cases what have been done through the night in the morning meeting. So I remember like the concept of this golden hour and everything. This is of utmost importance. And whenever in neurosurgery, we have emergencies, but when we talk about die-hard emergencies, that is the probably EDH. So this is something which requires immediate intervention. So whenever we used to present our cases in the morning, so our consultant used to check only and only one thing, not the pre-op scan, not the post-op scan, whatever the outcome was, that's separate. He only used to check the time of admission on the file and the time of incision time in the OT. So this is, I think, the most important point, and this is what we have been emphasizing over here, and I'm really happy to see that you have been promoting and executing that in Yatharth Hospital, and we really need to take it further to all across the Yatharth and probably more hospitals. So thank you, wonderful job.
Thank you, sir. Thank you.
Congratulations, ma'am. What I think, to save a patient, everybody in the ER has to know the basics. So if we stick by to the basics, everything will come into the picture and the patient will be saved. By making this code trauma, you have eased out the chaos. So what happens is when a patient comes, everybody starts doing ABC and everybody starts following that. And in that chaos, when too many cooks spoil the broth, that happens. By code trauma, everybody know when to intervene, when to enter into the picture, when to handle the patient, when to touch the patient. So this code trauma, I guess it should be universalized in every hospital so that everybody should know their work. It is just the basics, airway, breathing, circulation. If you maintain that, the patient will be saved. All the surgeries can be done later, but maintaining a hemorrhage, airway, breathing, circulation, if it's done in a proper way, I guess the patient life will be saved. Thank you so much.
I couldn't have said it better myself, so thank you.
Thank you so much, Dr. Shefali, for this wonderful talk and session. Also, our panels, thank you so much to join us on stage. Now, I would like to invite Dr. Gautami A.V., Chief Executive Officer at Yatharth, Noida 110, and Dr. Hamidi, HOD, General Surgery Department, Yatharth Hospital, Greater Noida, to felicitate our speaker and chairpersons. I'm requesting Dr. Gautami, please come on stage. So first we have Dr. Shefali Chandra. Ma'am, please. Dr. Nalini Bala Pandey. Dr. Nikhil Gupta. Dr. Prankul Singhal. And Dr. Farah Imam. Thank you so much, Dr. Gautami and Dr. Hamidi. Thank you so very much.
Next, we explore a session that captures the most crucial hour in trauma care. The topic, the golden hour begins with platinum. Our esteemed speaker for this session is Dr. T.S. Srinath Kumar, ex-president, Society for Emergency Medicine, India, treasurer, International Federation for Emergency Medicine, and Asian Society for Emergency, and Academic Council Chair, Society for Emergency Medicine, India. Chairing this high-energy session, we have a distinguished panel, Dr. Debmoy Ghatak, Consultant General Surgery, a trauma surgeon as dedicated and talented as it can be, AIMS Kalyani. Dr. Atul Kaushik, Professor and Head, Emergency and Critical Care, Al-Falah of Medicine Sciences and Research Center, Faridabad. Dr. Ankur Verma, Senior Consultant, Emergency, Medicine Max Hospital, Patparganj. President SEMI, Course Director for BLS and ACLS. He's also the Chair for Trauma Special Interest Group in IFEM. Dr. Shobhit Bhardwaj, Consultant, Orthopedics, Yatharth Hospital, Noida. This is going to be a high energy and high impact session. Please welcome Dr. Kumar and our esteemed chairpersons.
Good morning, everybody. It's a pleasure to stand in front of this august gathering and speak about the most important thing, which is also very close to my heart, because as an emergency physician, always three things will be more exciting. Among them, one is trauma, because when a trauma patient comes, like what my predecessors have told, it's very important to treat them at that particular second, not at the particular minute also. So it should always start with the platinum seconds than the golden hour. That's what it keeps telling. Just to give a glimpses, I was associated with one of the public-private projects in Hyderabad, Yashoda Hospitals. Previously, I was working there. So there, as you all know, it's a 160 kilometers of highway surrounding the Hyderabad city. So there was a lot of accidents which were happening, and a lot of people used to die before they reached the Hyderabad itself, too many hospitals, like what AIMS Rishikesh had done for their people. So we started looking into this, and they asked us to set up a trauma center every 10 kilometers. So that was the project which was given to us. So we took up 8 trauma centers, and other 8 trauma centers went to Apollo hospitals. So every trauma center should have 4-bedded emergency department, so emergency beds, along with trained paramedics, and then they have to be connected to the hospital directly. So that's how, so you can see there the 6 centers which is there. So you can see all the 6 centers there, sorry. So you can see all the 8 centers which we were managing there. And then we set up, every trauma center should have an ambulance there. And then every trauma center should have a emergency cart with the crash cart, everything. And that's how we started developing it. And every month, we could save thousands of lives. That's what we could see there. Sorry, I could not present the data there. So this is what we connected there and showed them from this one, and then that will be connected to the emergency department of the hospital. So we could give the platinum seconds what the patient has to be done at that particular moment, and then shift the patient to the hospital which is nearest and take care of these patients. So as we all know, it's very important that every second importance. And we know that there are 3 parts in the emergency department. One is your pre-hospital care, where the second starts, and then it's your in-hospital, where you triage a patient, and then you look into how you can save the patient. So in the pre-hospital, what I mentioned, all the 3 setups, that is your bike ambulance for all other medical emergencies, and if it is for your trauma patients, we know that it is the trauma ambulance services, which is very much required, and then bring the patient safely to the hospital, or the HEMS. Now, it's very proud to see that so much of HEMS has been utilized, and even government of Madhya Pradesh has taken in fact with HEMS to be introduced, and they are giving it free of cost for all the trauma patients. That's what I heard from my colleagues. So it is, then once the patient comes into the emergency, then we all know that it should be a triaging, which already the core trauma is there, and the trauma team is very important along with your universal precautions. What is our aim? Aim is always to reduce the morbidity and the mortality of the patient. How are you going to do this is the most important thing over the next 15 to 18 minutes, which I will be speaking upon. So preparation is always a key for any patient in the emergency department. So you could see again in government of Tamil Nadu, where you could see that there was a lot of patients who died, 18,000 patients who died on the road before they reached the hospital. So what we did in government of Tamil Nadu, along with Dr. Amit Gupta, who was there, so we established something called as Tamil Nadu Accident Emergency Initiative. So every district hospital should have 30 beds of emergency department with a well-equipped team. And we could see how we could reduce the mortality and morbidity in every district hospitals, where they converted that into the emergency department now, and every medical college has an MD emergency medicine with almost 3 to 5 seats in every place. So what we did in all these places was we told them what is most important, and they were all guided along with the NHM team and the project director of the Tamil Nadu accident. So we know how the core trauma works and where the people have to stay and how it has to be seen for. So what is the next important in your seconds? Go with your ABCDE protocol and you can save the patient in the timely manner. So I'll give you one of the examples. When I was working in one of the hospitals in Salem, I was the associate professor there in Vinayaka Missions Medical College. So during the lunch break, one of my close friend went out to have lunch. And suddenly we got a patient back to the emergency department in an ambulance. So then once we received the patient, he was not lying down flat on the trauma bed. He was just sitting down and he was showing his finger to the mouth. I was wondering why he was standing. We were 3 emergency physicians standing there and we could not recognize him. His whole face was mangled and he was just showing his finger like this. So then we searched his pockets and he had an ID card that was he was our own colleague, which he had gone for lunch and he had fallen down, and we had to bring him in the 108 ambulance brought him. And we could not intubate the patient, we could not do anything. At that particular moment, our aim was to save him and give the oxygen at whatever possible way. And you know what saved him? It just saved that needle cricothyrotomy, which we all practiced, and we could save him in that golden seconds, platinum seconds itself. And we could convert that needle cricothyrotomy, taking him to the OR and converting that into the surgical cricothyrotomy with the help of ENT surgeons. Multiple people were involved. So in that way, every person should know the airway anatomy and the airway, what is required, and the skills which yesterday, I think Yatharth Hospital has done a beautiful work yesterday by conducting such a good workshop, giving the knowledge to all the residents about the airway and all the skills which is required to save patients in a trauma. So that's how, which is important to know how to do the simple procedures. And every emergency department should have all the accessory guidelines and all the things which is required in airway management, because having a laryngoscope is not important today. Having the difficult airway kit is important today to save the victims in the emergency department with a polytrauma victim, even and checking them. That is, the preparation is the most important key. Having everything spread across and keep it in a trauma bay so that you know where it is and how to utilize it. Have a stillet, have a bougie, have a video laryngoscope, and the skills of needle cricothyrotomy, and also, if possible, to do the tracheostomy in the emergency department itself. So that is how it is important in the airway management, and also the retrograde intubation wherever possible, because seconds matter in an emergency situation. You should know both inline stabilization and giving the intubation, or needle cricothyrotomy or retrograde intubation where it is required. So, and finding out at that right time where you have to put the needle and how you have to perform the needle cricothyrotomy is the most important thing, which every person should know the skills. Sorry. So then the breathing resuscitation, we all know. Next, our speaker we'll be speaking about more of chest trauma and telling more about the chest trauma thing. The resuscitative techniques, when there is a blunt trauma chest in the emergency department itself, will save lots and lots of lives, which is important. not only forgetting that the wearing of seat belt is not only important, but seat belt injuries is also important, because when a patient hits himself and with the seat belt, many a times until you expose the patient and see, you may not be able to see the seat belt injuries. Until you expose and see, and then what you have to do, that is the most important key in your resuscitative techniques, especially when there is a breathing, and those are the very important things. Open chest traumas, again, how you have to put the techniques, and then exactly where you have to do for the open pneumothorax as well as for the tension pneumothorax, because you know one of the reversible causes of cardiac arrest is nothing but tension pneumothorax, and where you have to do the needle thoracotomy and where you have to put the ICD is important. Without that, you may not proceed to save a patient, and that's the resuscitation skill in the seconds which matters. So placing an ICD is important in the emergency department itself for every needle.
आए स्टेज पे और हमें यथार्थ की जर्नी के बारे में बताएं.
हमारे प्रदेश के लोकप्रिय जन कल्याणकारी माननीय उप मुख्यमंत्री जी, स्वास्थ्य एवं परिवार कल्याण, मातृत्व एवं बाल कल्याण एवं चिकित्सक शिक्षा के कैबिनेट मंत्री जी, हम आपको यहाँ पे देख के बहुत ही गौरवान्वित महसूस कर रहे हैं, और आपने अपना अमूल्य समय दिया। हमें मालूम है कि आज आप इतने व्यस्त थे, उसके बाद भी आप यहाँ पे आए। हम यहाँ पे सभी जो उपस्थित हैं यहाँ पे और यथार्थ ग्रुप के सभी लोगों की तरफ से मैं आपका हार्दिक अभिनंदन करता हूँ। मंच पे उपस्थित यथार्थ ग्रुप के चेयरमैन डॉक्टर अजय त्यागी, मेरे बड़े भाई डॉक्टर सुषमा सागर जी, और यहाँ पर आए बहुत ही सीनियर डॉक्टर्स, ट्रॉमा सर्जन्स जो कि हैदराबाद से आए हैं, महाराष्ट्र से आए हैं, तेलंगाना से आए हैं, केरल से आए हैं, कर्नाटक से आए हैं, उत्तराखंड से आए हैं, पंजाब से आए हैं, भोपाल से आए हैं, दिल्ली से आए हैं और इस हमारे उत्तर प्रदेश से आए हैं। मैं सभी का हार्दिक अभिनंदन करता हूं। और ये जो ट्रॉमा की एक कॉन्फ्रेंस हुई है, ये सच में बहुत ज़रूरी है और उसके कुछ कारण भी हैं। जैसा हम सभी जानते हैं, हम डॉक्टर्स तो जानते हैं कि ट्रॉमा जो अननेचुरल डेथ होती हैं, वो सबसे बड़ा कारण है मृत्यु का, और करीब करीब 43% अननेचुरल डेथ ट्रॉमा से होती है। ट्रॉमा खाली उस इंसान को नहीं होता जो सड़क पे गंभीर रूप से घायल होता है या उसकी मृत्यु हो जाती है। ट्रॉमा उसके परिवार को होता है, ट्रॉमा उसकी पत्नी को होता है, ट्रॉमा उसके बच्चों को होता है, और एक तरीके से पूरा परिवार बिखर जाता है। हमने कोशिश की, पिछली साल भी ट्रॉमा के ऊपर कॉन्फ्रेंस की, और यहाँ पे कमिश्नरेट में भी हमने, जो हमारी कमिश्नर महोदया हैं यहाँ पे, उनके साथ भी एक बड़ी ट्रेनिंग हुई जिसमें सभी पुलिस वालों को CPR ट्रेनिंग दी गई, और साथ में ये भी बताया गया कि किस तरीके से पेशेंट को हॉस्पिटल पहुँचाना है, कौन से ऐसी बॉडी के पार्ट्स होते हैं उनको अच्छी तरीके से कैसे हम मैनेज कर सकते हैं उस जगह पे जहाँ पे वो चोट लगती है उसको, क्योंकि सर्वाइकल स्पाइन एक ऐसी चीज़ होती है, इसमें अगर इंजरी हो जाए, अगर ठीक से पेशेंट को नहीं उठाया तो उसकी वहीं पे मृत्यु हो सकती है। तो ये सब चीज़ें हुई हैं, और कोशिश यही है कि हम अपने कम से कम इस क्षेत्र में, जैसा हमने बात भी की, अपने पुलिस के जितने भी और भी अधिकारी उनसे भी बात हुई, और पुलिस के आप सभी जानते हैं सरकार की तरफ से एम्बुलेंसेस भी होती हैं, इमरजेंसी रेस्पॉन्स टीम भी होती है, और पुलिस के अधिकारी, पुलिसकर्मी वहाँ पे होते हैं, कैसे एक मरीज जो एक गोल्डन पीरियड होता है ट्रॉमा का 1 घंटे का, वो अस्पताल तक पहुँच पाए। और उसमें काफ़ी हद तक सफल भी हुए हैं और चीज़ें अच्छी डायरेक्शन में जा भी रही हैं। मैं आज ज़रूर नाम लेना चाहूँगा अपनी 2 बहनों का, डॉक्टर फरा, डॉक्टर शेफाली। प्लीज़ खड़े हो जाइएगा और एक बार ज़ोरदार तालियां बजाइएगा। आज डॉक्टर शेफाली जो ट्रॉमा सर्जन हैं और डॉक्टर फरा जो कि इमरजेंसी हेड हैं, आज इन्हीं की वजह से हम यहाँ बैठे हैं और करीब करीब आज 13 से 14 प्रदेश के, भारतवर्ष से ट्रॉमा सर्जन्स यहाँ पे आए हैं। आज सुबह और भी बहुत सारे लोग थे, कुछ लोग चले भी गए अपने लेक्चर्स वगैरह दे के, और मुझे लगता है कि आपका जो ये प्रयास है बहुत ही फ्रूटफुल होगा और पूरे चिकित्सा जगत में इसकी एक अलग पहचान भी जाएगी कि हाँ, कि ट्रॉमा को कैसे मैनेज किया। थैंक यू वेरी मच। और साथ में आप बैठ जाइए प्लीज़। थोड़ा सा जैसे मुझसे बताया गया कि यथार्थ की यात्रा के बारे में भी बताएं थोड़ा सा, तो इतना ही कहूँगा कि हम उत्तर प्रदेश के बगल का ही एक ज़िला है बुलंदशहर, उसमें एक छोटा सा गांव है श्याना, वहाँ के रहने वाले हैं। और पिता खेती करते थे, हम भी खेती करते थे, और नहीं सोचा था कि ऐसे कि हम डॉक्टर बन भी सकते हैं। वो मुझे लगता है वो हमारी माँ ही थी जो हमारे पीछे पड़ी, नहीं आगे बढ़ना है, खेती नहीं करनी है। जमींदार होते हैं तो कई बार नहीं पढ़ते हैं बच्चे, और उस क्षेत्र के मैं और डॉक्टर अजय पहले सरकारी मेडिकल कॉलेज वाले में जाने वाले MBBS करने के लिए गए वहाँ पे, और उसके बाद से ये जर्नी शुरू हुई। शुरू में जैसे बताया कि किसान परिवार से आते थे तो पैसा धन तो नहीं था कि कुछ कर पाएंगे आगे, तो शुरू में 1996 में डॉक्टर अजय और भाभी डॉक्टर नीना ने श्याने में ही एक छोटा सा नर्सिंग होम स्टार्ट किया। मैं और मेरी पत्नी डॉक्टर मंजू 2003 में MBBS किया, MS किया, उसके बाद SRशिप की। डॉक्टर मंजू ने MD मेडिसिन की और SRशिप सफदरजंग से की। फिर यही था कि क्या करें, अब कहाँ जाएं और कैसे स्टार्ट करें। तो 2003 में ही यहाँ पे नोएडा में शुरुआत की, और प्रभु की कृपा ही थी और माता पिता का शायद आशीर्वाद रहा कि पहले दिन से ही सब चीज़ें बहुत अच्छी डायरेक्शन में जाने लगी। और शायद ये एक नेक नीयत और सही दिशा जो दी माँ ने, उसी का नतीजा है कि आज यथार्थ एक यथार्थ ग्रुप है। 2010 में पहला अस्पताल बना, फिर 2013 में दूसरा बना, 2018 में एक्सपेंशन हुआ, 2019 में चौथा बना, 2022 में 5वां बना, और अभी 6ठा अस्पताल MD मॉडल टाउन में दिल्ली में 14 तारीख को ही इसका लोकार्पण होने वाला है। और एक अस्पताल इसी महीने फरीदाबाद में भी, उसका भी लोकार्पण होने वाला है। इस तरीके से ये एक छोटी सी यात्रा रही, और मुझे यही लगता है कि ये प्रभु की ही कृपा है और माता पिता का आशीर्वाद है कि हम उन्हीं के कहने पे जो उन्होंने हमें सीख दी उसी नियत पे आगे बढ़ रहे हैं। और साफ मन होता है और नियत साफ होती है तो प्रभु जो है हाथ पकड़ता ही है, उसने पकड़ा। ये एक छोटी सी भौतिक यात्रा जरूर रही है। नहीं सोचा था कि हमने अस्पताल बना पाएंगे, एक भी बना पाएंगे, पर हुआ। एक आध्यात्मिक यात्रा भी छोटी सी मेरी है, उसके बारे में भी जरूर कहना चाहूँगा। मैं 1990 में आगरा से मेडिकल करने गया था, 89 में गया था, तो वो 1990 में एक ऐसे शख्स मिले जिन्होंने पूरा व्यक्ति निर्माण ही कर दिया, जिनका काम ही शायद व्यक्ति निर्माण का था और है। राष्ट्रीय स्वयंसेवक संघ के माननीय सह सरकारवा आदरणीय डॉक्टर कृष्ण गोपाल जी उस समय आगरा में विभाग प्रचारक थे, और वो हमारे हॉस्टल में आते थे, बड़े आराम से आम खिलाते थे काट काट के अपने हाथों से। और हमें नहीं पता था कि हाँ, कि हमारा कुछ क्या हो रहा है। एक मित्रता उनसे हो गई, रोजाना कई हफ्ते में 3-3 4-4 बार मिलते थे। छोटे छोटे उन्होंने कहा कि अब जो है ग्रामीण बस्ती में जाओ, वहाँ पे काम करो, और करने लगे। 2012 में उन्होंने कहा कि जो उत्तराखंड है उसमें बहुत ज़्यादा प्रॉब्लम है, वहाँ परेशानियाँ हैं, और 3 उद्देश्य उन्होंने बताए। एक धर्मांतरण, पलायन, और तीसरा सामरिक दृष्टि से जो हमारे जो चीन का बॉर्डर है उसके आसपास के जो गांव हैं वो बहुत ही महत्वपूर्ण हैं। और चौथा, जो हमारे हिंदू श्रद्धालु इतनी दूर दूर से आते हैं चारों धाम में यात्रा के लिए, उनको वहाँ पे कोई चिकित्सा सेवा उपलब्ध नहीं थी। तो उसी सोच के साथ में आगे बढ़े, जैसा जैसा उन्होंने कहा, जैसा उन्होंने विज़न दिया। आलोक जी भाई साहब थे उस टाइम वहाँ पे क्षेत्रीय प्रचारक थे, आज आप सह सरकारवा जी हैं। उन्होंने भी बड़ा सहयोग दिया हर चीज़ के, आगे आगे बढ़ के ज़मीन दिलाई हॉस्पिटल के लिए, हॉस्पिटल का लोकार्पण में, सब चीज़ों में उन्होंने मदद करी। और आज बड़ा अच्छा लगता है सोच के कि उत्तराखंड के अंदर 14 अस्पताल स्वामी विवेकानंद हेल्थ मिशन सोसाइटी के चल रहे हैं, और उन सभी अस्पतालों में ये सौभाग्य की बात है कि यथार्थ ने वहाँ पे सारे वो हॉस्पिटल, मैं इसको ज़्यादा नहीं कहना चाहता, पर हाँ इतना ज़रूर कहना चाहता हूँ कि वो जो हॉस्पिटल जो चल रहे हैं इस टाइम, बद्रीनाथ, केदारनाथ, गंगोत्री, चारों धामों के मार्ग में, एक धर्मावाला, एक अल्मोड़ा पेटसाल में, एक हरिद्वार में, जो ऊपर धाम के अस्पताल हैं। एक छोटा सा एग्जाम्पल देता हूँ मैं। अभी यात्रा को चलते हुए कितने दिन हुए हैं? 10 मई के आसपास यात्रा स्टार्ट हुई थी केदारनाथ में। मई, जून और जुलाई, पूरे 2 महीने के आसपास अब होने वाले हैं। आप सोच के दंग रह जाएंगे, करीब करीब 1.5 लाख मरीज उस केदारनाथ अस्पताल में देखे गए हैं, और उसमें से करीब करीब 25,000 की इमरजेंसीज थी। इमरजेंसी ऐसी जो एक्यूट इमरजेंसी, किसी को एमआई, किसी को हाइपोथर्मिया, किसी को सीओपीडी है तो लंग्स की प्रॉब्लम होगी, ऑक्सीजन की कमी हो गई। और अच्छा लगता है सोच के कि हाँ, कि यथार्थ भी जो है उसमें हम सौभाग्यशाली हैं। आज पूरी जो केदारनाथ की टीम है वो यथार्थ हॉस्पिटल से ही वहाँ पे गई हुई है और सारे काम कर रही है वो। इसी तरीके से गंगोत्री, बद्रीनाथ में और सारे धामों में काम चल रहा है और अच्छे से कर पा रहे हैं। और आप नहीं समझते कि कब व्यक्ति का निर्माण हो गया और वो हो गया, तो अच्छी बात है। ये छोटी सी आध्यात्मिक और एक भौतिक यात्रा यथार्थ की रही है। आज मैं इतना ही कहना चाहूँगा कि आप 10-12 प्रदेश से सब यहाँ डॉक्टर्स आए, इतने सीनियर डॉक्टर्स आए हैं, और कुछ स्टूडेंट्स भी आए हैं, उन्होंने भी बहुत कुछ सीखा होगा। और ट्रॉमा, हम किसी को ट्रॉमा ना होने दें, ये सोचें, और कैसे उसको हम बचा सकते हैं इसके बारे में आगे विचार करें, और जितना भी अच्छा कर सकते हैं उतना करें। और अंत में एक बार फिर मैं हमारे लोकप्रिय उप मुख्यमंत्री जी श्रीमान डॉक्टर ब्रजेश पाठक जी का बहुत बहुत हार्दिक अभिनंदन करता हूं, हृदय की गहराई से धन्यवाद देता हूं कि इतने बिजी कार्यक्रम के बावजूद भी आप यहां पे आए। बहुत बहुत धन्यवाद।
धन्यवाद, बहुत बहुत धन्यवाद कपिल सर। अब मैं चाहूँगी कि हमारे माननीय श्री ब्रजेश पाठक जी आएँ और कुछ 2 शब्द अपने साझा करें हमारे साथ।
यथार्थकॉन ट्रामा 2.0 कार्यक्रम में उपस्थित डॉक्टर सुषमा सागर, एम्स की हेड ऑफ डिपार्टमेंट, डॉक्टर अजय त्यागी, चेयरमैन यथार्थ हॉस्पिटल, डॉक्टर कपिल त्यागी, एमडी यथार्थ हॉस्पिटल, और यथार्थ जी जिनका उद्बोधन हमने प्रारंभ में सुना, भारतीय जनता पार्टी गौतम बुद्ध नगर के जिला अध्यक्ष अभिषेक शर्मा जी, विभिन्न प्रदेशों से आए हमारे चिकित्सक बंधु, स्टूडेंट्स, भाइयों तथा बहनों, सबसे पहले यथार्थ हॉस्पिटल्स को मैं बहुत बहुत बधाइयाँ देता हूँ, आभार प्रकट करता हूँ और शुभकामनाएं भी देता हूँ। यथार्थ हॉस्पिटल की यात्रा के बारे में हम सब पहले से वाकिफ थे। यथार्थ हॉस्पिटल जैसे चिकित्सक का काम होता है सेवा कार्य, तो धन कमाने के लिए नहीं, सेवा के लिए बना। और ये इन्होंने धरातल पर जाकर के सिद्ध भी किया है, चाहे हमारे सुदूर दुर्गम पहाड़ी क्षेत्र में हो या मैदानी क्षेत्रों में हो, यथार्थ हॉस्पिटल ने सेवा कार्य में अपना अच्छा योगदान दिया है। उसके लिए यथार्थ प्रबंधन का मैं हृदय से बहुत बहुत अभिनंदन करता हूँ, बधाइयाँ भी देता हूँ, शुभकामनाएं देता हूँ। जहाँ तक ट्रामा की चर्चा हम सब करते हैं, हम सब जानते हैं कि मानव जीवन अमूल्य है और जानबूझ करके हम विपत्ति को बुलाने का काम करते हैं। सामान्यतः जो ट्रामा के ज़्यादातर केसेज हैं वो रोड एक्सीडेंट्स के हैं। अन्य एक्सीडेंट्स भी होते हैं, लेकिन रोड एक्सीडेंट की संख्या बहुत अधिक है। समय समय पर उत्तर प्रदेश सरकार और केंद्र सरकार इस संदर्भ में सड़क परिवहन मंत्रालय के माध्यम से कॉन्फ्रेंसेज भी आयोजित होती हैं। लेकिन दुनिया में भी जितने भी दुर्घटनाएं होती हैं, उनकी यदि हम तुलना करें तो ये पाते हैं कि भारत में और उत्तर प्रदेश में दुर्घटनाएं बहुत अधिक हो रही हैं। हम भी उत्तर प्रदेश की विशेष रूप से चर्चा करेंगे। आज के 30 वर्ष पहले जो हमारी उम्र के साथी हैं वो जानते होंगे कि गाड़ियों पर लिखा रहता था, जो हैवी व्हीकल्स होते थे, गति सीमा 40 किलोमीटर। लेकिन अब गति सीमा नहीं है। हमें याद है जब नई गाड़ी ली जाती थी तो उसमें गवर्नर लगा दिया जाता था। आज के बच्चे तो, आने वाली पीढ़ी गवर्नर के बारे में, गाड़ी में भी गवर्नर लगेगा, वो उनको मन में विचार ही नहीं आएगा कि इससे ऊपर गाड़ी ही नहीं चलेगी। 80 से 90 के बीच में जब प्रिया स्कूटर लेते थे, कहते थे अभी नया है, इंजन बना है, तो इसमें अब जो है 30 से ऊपर, 35 से ऊपर नहीं चलेगा। लेकिन अब गति की कोई लिमिट नहीं है। जिस एक्सप्रेसवे से मैं बिजनौर से चल करके आपके बीच में पहुंचा हूं, हमने कई गाड़ियों को देखा जो 100 से ऊपर बहुत आराम से जा रहे थे, और कई कार सवार ऐसे थे जो बड़ी गाड़ियों से थे, उनकी गति सीमा हो सकता है कि 150 से भी ऊपर हो। मानव जीवन अमूल्य है, ये जानते हुए भी हम माता पिता की, अपने गुरुजनों की, समाज के लोगों की चिंता न करते हुए अचानक गति के पीछे पड़े। यह हो सकता है कि अचानक कोई काम आ गया, कोई ट्रामा ही है, उन परिस्थितियों में तो गति को बढ़ा सकते हैं। लेकिन यदि सामान्य परिस्थितियां हैं तो हमें गति को नियंत्रित रखना हमारा प्रथम कर्तव्य होना चाहिए। और हम स्कूल कॉलेजेस के माध्यम से बच्चों को, नौजवान पीढ़ी को यह जरूर बताएं कि दुर्घटना को बुलाना नहीं है, दुर्घटना हो जाती है, लेकिन युवा पीढ़ी दुर्घटनाओं को बुलावा देने का काम कर रही है। हमें गति को सीमित रखना है और प्रदेश को और देश को आगे बढ़ाने के लिए काम करना है। हमारे चिकित्सक भाई बहन बैठे हैं। सामान्यतः जितने भी चिकित्सकों के बीच में कॉन्फ्रेंसेस में मुझे जाने का अवसर मिलता है, वो बीमारियों के निदान के लिए होती हैं। जैसे ट्रामा में हम कैसे इलाज करें। हमारी 2 सिस्टर्स को आपने सम्मानित किया, उन्होंने अच्छा ट्रामा में काम किया है, ट्रामा के इमरजेंसी में सर्जन है, अच्छा काम किया है। लेकिन हमारे चिकित्सक बंधु, चूंकि समाज में आपका रूप भगवान के बाद आपका ही नंबर आता है। शिक्षक और चिकित्सक दोनों ऐसे हैं जो जीवन एक गढ़ने का काम करता है और एक जीवन बचाने का काम करता है। आप ईश्वर के रूप हैं। तो हम लोगों को इस बात की चर्चा जन जन में पहुंचानी चाहिए कि ट्रामा हो ही ना, और यदि है भी तो उसका परसेंटेज हम कम करने का प्रयास करें। और बीमारी को हम क्यों बुलाते हैं? आप सोचते होंगे कि जितनी भी बीमारियां हैं उसमें से मैं कह सकता हूं कि 60% से अधिक बुलाई हुई बीमारियां हैं। आप लोग सब चिकित्सक हैं, जानते हैं शरीर एक मशीन की तरह काम करता है। अब जिस शरीर को जो आवश्यकता है वही आप इसमें भरेंगे, या इसको खुराक देंगे, या उसको इनपुट उसको वही देंगे जो इसकी आवश्यकता है। लेकिन आप सोचिए कि हमको मानव जीवन जो अमूल्य है, हम उधर ध्यान नहीं देते। जो भी मिल गया उसको हमने खा लिया, जो भी मिल गया उसे ग्रहण कर लिया, और फिर कोई अचानक बीमारी आई तो डॉक्टर साहब पहुंच गए, डॉक्टर साहब आज जो है पेट दर्द हो रहा है। पेट दर्द क्यों हो रहा है? इस पर चर्चा तो होनी चाहिए। भाई मानव जीवन को, एक युवा शरीर को जो अंडर 40 है या अबव 40 है, उसकी कितनी कैलोरी चाहिए? सभी पढ़े लिखे लोग हैं, सबके हाथ में मोबाइल है, तो जितना जरूरत उतना ही तो खाना है मुझे। हम अतिरिक्त रूप से भोजन ग्रहण कर रहे हैं, और जब भोजन ग्रहण करेंगे तो फैट आएगा, फैट आएगा तो कई बीमारियां आएंगी, तो लीवर फैटी हो जाएगा, लीवर फैटी हो जाएगा, डॉक्टर साहब कितने दिन चलेगा? फिर पता चला कि शुगर हो गया है, ब्लड प्रेशर हो गया है, फिर चला नहीं जा रहा है। ये सब क्यों है? सबसे पहले तो हमें तय करना चाहिए प्रत्येक व्यक्ति को कि हमें 40-45 मिनट पसीना निकालना ही निकालना है रोज सुबह, और हमें सूर्य के साथ चलना है। होता क्या है, जितने युवा पीढ़ी पीछे बैठी है, पूछिए कि रात में इंटरनेट अच्छा चलता है? भ्रांति फैल गई, कोई भी 3 बजे 4 बजे के पहले सोने को तैयार नहीं है। 8 बजे की क्लास है, जल्दी जल्दी उठ के भागे, नींद आई यही है, स्कूल में भी औंघाई ले रहे हैं, कैसे काम चलेगा? इंटरनेट दिन में भी अच्छा चलता है, दिन में भी अच्छा काम हो सकता है, और शरीर हमारा सूर्य के प्रकृति के हिसाब से हमें चलना है। अगर हम सुबह 5 बजे नहीं उठ सकते, 5:30 उठ जाओ, 6 उठ जाओ, 50 मिनट केवल हम फास्ट वॉक कर लें, बैडमिंटन खेल लें, कुछ न करें, घर में झाड़ू पोछा कर लें, कुछ न कर पाए तो घर की सामान की जो अलमारी है, कपड़े और किताबें, उसको पलट दीजिए, वो दोबारा रख लीजिए, आपकी एक्सरसाइज कंप्लीट हो जाएगी। 40-50 मिनट पसीना निकालना ही निकालना है। और हम कर क्या रहे हैं? अब तो इतना ज्यादा हम लोग कष्ट न सहने की आदी हो चुके हैं कि गाड़ी बेडरूम तक जाना चाहिए। नोएडा में हमारे पास ढेर सारी शिकायतें आती हैं। यहां हाई राइजेज बिल्डिंग बन गई है, पार्किंग के लिए रोज झंझट हो रहा है कि नहीं हो रहा है? एवरी डे ऐसी कंप्लेंट्स हमें आती हैं। तो मेरा आप सबसे अनुरोध है कि हमारे चिकित्सक भाई बहन हैं, इस नैरेटिव को हमें जन जन तक पहुंचाना है कि अपने शरीर को स्वस्थ रखने के लिए एक्सरसाइज बहुत आवश्यक है। प्रातः काल उठना है, हमें वही ग्रहण करना है जो हमारे शरीर के लिए अनुमन्य है। और एक बात और हमने जर्नल देखा है, सामान्यतः जो पार्टियां होती हैं जिनको हम हाई क्लास या फेज 3 पार्टियां बोलते हैं, उनमें हम क्या कर रहे हैं? हम सब चिकित्सक हैं और लोगों को ज्ञान भी नहीं दे पा रहे हैं कि हमें शरीर को वही देना है जो शरीर को स्वीकार है। अतिरिक्त क्यों हम ऐसा काम कर रहे हैं जिसकी शरीर को स्वीकार्यता नहीं है? एक गांव में हम गए, उत्तर प्रदेश के सुदूर नेपाल की तराई का गांव था, तो मुझे एक स्टेडियम का उद्घाटन करना था। लोगों ने कहा 7 बज गया साहब, अब जाना ठीक नहीं, गांव में पूरा गांव मस्त होगा इस समय। तो मैं गया, मंच पे एक बालक खड़ा था थोड़ा दूर, मैंने उसे बुलाया, तो हमने क्या हुआ, नई मोटरसाइकिल से आया था, उस पर नंबर भी नहीं पड़ा था। हमने कहा मोटरसाइकिल आपने 80,000 की खरीदी हो कल? हाँ। हमने कहा इसमें अगर मिट्टी तेल के डाल के चलाया जाए तो चलेगी? कहाँ चलेगी? तो हमने कहा 6 महीने तक चलाओ, हम आपका जुगाड़ करते, 6 महीने का तेल फ्री दिलाते। कह रहे हम पागल हैं क्या, 6 महीने में तुम्हारा इंजन बैठ जाएगा, नई मोटरसाइकिल है। तो मैंने उससे हाथ जोड़े, हमने कहा भाई ये शरीर जो अमूल्य है, इसमें कितने वर्षों से आप उस अनधिकृत तरल पदार्थ को स्वीकार कर रहे हो जिसके लिए शरीर नहीं बना है। हम सब प्रबुद्ध वर्ग से आते हैं, हमें जन जन तक पहुंचाना होगा। और ट्रामा की चर्चा यदि हम करें तो ट्रामा में हमें गति को कैसे सीमित करना है। हमने सरकारी मीटिंगों में ऑफिसर्स को भी कहा है, आप देखते होंगे जो हमारे एक्सप्रेस वेज हैं, हमने वहां लोकल पुलिस को लगाया है, साथ में हमारे यहाँ जो 112 पुलिस की गाड़ियां वो भी लगातार गश्त पर रहती हैं, हमने एम्बुलेंसेज खड़ी रखी है। और हमने ये भी कहा कि हमें वार्निंग सिस्टम लगाने होंगे, गाड़ियों से आने वाले दिनों में इस आवाज को सुनेंगे आप, कृपया 100 के नीचे चले, आप खतरे के निशान के ऊपर जा रहे हैं, आपकी गाड़ी की स्पीड अधिक है। हमने कहा है कि आप लाउड स्पीकर लगा करके हाईवेज पर अनाउंस करिए। हमने उत्तर प्रदेश सरकार के ऑफिसर्स को इस बात को कहा है। होता क्या है कि गाड़ी आपने अच्छी ले ली है और युवा हैं, 18 पार कर गए हैं, ड्राइविंग लाइसेंस बन गया है, नहीं बन गया है, गति को चेक करने के लिए हम जा रहे हैं। ऐसा नहीं करना है। शरीर अमूल्य है, आपके जन्म किसी दूसरे उद्देश्य के लिए ईश्वर ने हमें भेजा है, और उस उद्देश्य को प्राप्त करने के लिए हमको भारत भूमि को नमन करना है। भारत भूमि कोई साधारण भूमि का टुकड़ा नहीं है, ये देवों की भूमि है। और भारत ने समय समय पर अपनी उपयोगिता को दुनिया के पैमाने पर सिद्ध करने का काम किया है। आज जो भी डेवलपमेंट हम देखते हैं, अभी जो इंटरनेशनल वार्स चल रहे हैं, रोज हम टेलीविजन पर गाइडेड मिसाइल की चर्चा करते हैं कि ऐसे ऐसी मिसाइल बन गई, अगर जिस बेडरूम में, जिस तल पे हमारा फ्लैट है, पता चला कि दुश्मन को ही उसी बेडरूम में जाकर के मिसाइल लग रही है। गाइडेड मिसाइल की चर्चा अब हो रही है, लेकिन दुर्भाग्य से राजा दशरथ के बाण को जो श्रवण कुमार को लगा था वो शब्दभेदी बाण था, ऐसा हमारे पुरानी गाथाओं में हमें सुनने को मिलता। उस समय शब्दभेदी बाण था, तो आज क्या है? सब कुछ हमारे वेद पुराण उपनिषद कह चुके हैं। भारत की गाथा को, उसको हमें बरकरार रखना, उससे आगे ले चलना है। ट्रामा की इस कॉन्फ्रेंस में मैं सभी चिकित्सकों का अभिनंदन करता हूं और उम्मीद करता हूं, केवल एक बात मैं कहना चाहता हूं, ट्रामा में जो गोल्डन आवर है, उस समय यदि परिजन नहीं है तो आप क्या करने वाले हो? सामान्यतः क्या होता है कि ट्रामा में पेशेंट पहुंचा तो एक लिस्ट उसको पकड़ा दी, परिजन को जाओ लेके आओ। वो क्या है? मैं हाथ जोड़ करके निवेदन करता हूं, हमारे ज्यादातर यहां चिकित्सक प्राइवेट क्षेत्र के होंगे, कुछ हो सकता सरकारी क्षेत्र के भी हों। सरकारी में तो व्यवस्था ऐसी है कि ऐसा कोई नहीं रोकने वाला है। प्रथम चरण पे तो उसको मरीज को इलाज देना है। हम सबको ईश्वर का प्रतिरूप जनता मानती है और समाज मानता है, तो हमको प्रथम चरण में मरीज से कुछ नहीं पूछना है। और हर अस्पताल के गेट पर कम से कम 2 व्यक्ति ऐसे ट्रेंड होने चाहिए जो ट्रामा के इमरजेंसी में जो भी व्यक्ति आ रहे हैं उनको तत्काल बेड पर पहुंचाएं और इलाज शुरू करें। और वो चिकित्सक हो या आवश्यक नहीं है, चिकित्सक तक पहुंचा दें उस मरीज को। सामान्यतः जो कुछ मिनट होते हैं, मरीज के परिजन या एम्बुलेंस या कोई सामान्य गाड़ी लेकर के जो अस्पताल के गेट पर पहुंचती है, उसके कुछ सेकंड इसी में बर्बाद हो जाते हैं कि किधर जाना है मुझे, ये रैंप किधर पहुंचाएगा, ये सीढ़ी कहाँ पहुंचाएगी, ये रास्ता किधर को जाता है। कोई अगर अलर्ट व्यक्ति हमारे ट्रामा के गेट पर रहेगा, इमरजेंसी के गेट पर रहेगा, तो हमारे मरीज की जान बचाने में हमें सहूलियत मिलेगी। मुझे लगता है ट्रामा की इस कॉन्फ्रेंस के बाद हम सब जब अपने कार्य क्षेत्र में वापस लौटेंगे तो यहाँ से कुछ सीख करके जाएंगे। और ये मैं यथार्थ हॉस्पिटल के जो इस कॉन्फ्रेंस के आयोजक हैं उनसे कहना चाहूँगा, यदि आपकी कॉन्फ्रेंस में कुछ पॉजिटिव रिजल्ट निकलता है तो आप मुझे बताएं। सरकार की कुछ नीतियों में यदि परिवर्तन करना, चेंज करना है, तो मैं आपके साथ खड़ा हूँ कि उन कौन सी ऐसी बातें हैं जिनको चेंज करके हम बेहतर ढंग से और लोगों की जान बचा सकते हैं। मैं बहुत बहुत आभार प्रकट करता हूं यथार्थ हॉस्पिटल्स के मैनेजमेंट का, आप सबका, कि आपने मुझे बुलाकर अपने लोगों से मिलने मिलाने का अवसर प्रदान किया। माननीय प्रधानमंत्री नरेंद्र मोदी जी के मार्गदर्शन में पूरे देश में चिकित्सा जगत में अभूतपूर्व परिवर्तन हो रहे हैं। नए मेडिकल कॉलेज खुल रहे हैं, आप सब जानते हैं। उत्तर प्रदेश में मात्र 17 मेडिकल कॉलेज सरकारी क्षेत्र में थे, आज 80 से अधिक मेडिकल कॉलेज पूरी क्षमता के साथ काम कर रहे हैं। नर्सिंग कॉलेजेज, पैरा मेडिकल कॉलेजेज, और सबसे बड़ी बात है नीचे तक नेटवर्क हमने पहुंचाने का काम किया है। स्वास्थ्य उपकेंद्र, जो इनको स्वास्थ्य आरोग्य मंदिर भी कहते हैं, 5000 की आबादी तक खुले, इसको सुनिश्चित करने के निर्देश माननीय प्रधानमंत्री जी ने हम सबको दिए हैं और लगातार इस दिशा में हम काम कर रहे हैं। मुझे लगता है कि आने वाले दिनों में हेल्थ नेटवर्क अपने देश का दुनिया के किसी भी मामले में हम कमजोर नहीं होंगे। प्राथमिक चिकित्सा से लेकर ट्रामा से लेकर जो हमारे विशेषज्ञ चिकित्सक हैं, हर स्थिति से निपटने के लिए समय समय पर काम कर रहे हैं। अभी कुछ दिन पूर्व हम एक हार्ट की कॉन्फ्रेंस में गए थे। सामान्यतः हम लोग सोचते हैं कि अगर बाईपास है तो मुझे खोलना पड़ेगा हृदय को या हमें पसलियां काटना पड़ेंगी। अब आने वाले दिनों में ये भी संभव हो पाएगा कि बाईपास करना नहीं पड़ेगा, बाईपास तो हो जाएगा लेकिन पसलियां काटना नहीं पड़ेगी, ऊपर से ही संभव हो पाएगा। ऐसे आपको शीघ्र ही सूचनाएं मिलने वाली हैं। चिकित्सा विज्ञान में अपने देश में ही सब कुछ संभव होने जा रहा है जो दुनिया में हो सकता है। माननीय प्रधानमंत्री जी और हमारी सरकार लगातार इस दिशा में काम कर रही है। एक सबसे बड़ा गेम चेंजर योजना प्रधानमंत्री जी जो लेकर के आए, आयुष्मान भारत। आप सोचिए, गरीब आदमी को कौन पूछता था? गरीब के गहने बिकते थे, खेत बिकता था, उसका घर बिकता था। 5 लाख तक के निःशुल्क इलाज की गारंटी पूरे कंट्री को लोगों को देना, और पूरी दुनिया की सबसे बड़ी स्वास्थ्य योजना है। मैं कह सकता हूं कि माननीय प्रधानमंत्री जी ने भारत के उत्तर प्रदेश के गरीबों को एक बड़ा सोशल सिक्योरिटी देने का काम किया। हर गरीब के जेब में आज 5 लाख तक के निःशुल्क इलाज की गारंटी है। और मैं उम्मीद करता हूं कि आप सब इस कॉन्फ्रेंस के माध्यम से देश और उत्तर प्रदेश के लोगों को जन जन तक ट्रामा के क्षेत्र में और बेहतर क्या हो सकता, सहूलियतें क्या हो सकती है, इस दिशा में जरूर कुछ निष्कर्ष पर जाएंगे और उस पेपर्स का हम इंतजार करेंगे जो कॉन्फ्रेंस के बाद मुझे मिलने वाला है। यदि हमें कुछ नीतियों में परिवर्तन करना है उस दिशा में हम जरूर काम करेंगे। इन्हीं शब्दों के साथ मैं आप सबका आभार प्रकट करता हूं। बहुत बहुत धन्यवाद।
आदरणीय मुख्यमंत्री जी का हम हृदय से आभार प्रकट करते हैं, जिन्होंने अपने प्रेरणादायक शब्दों से हमें दिशा और ऊर्जा प्रदान की। आपके विचार हम सभी के लिए मार्गदर्शक हैं। मैं अनुरोध करूंगी रिस्पेक्टेड चेयरपर्सन से कि वे अपना अपना स्थान ग्रहण करें। Let's continue with the previous session of this evening. I'm requesting again Dr. James, Dr. Gyan Saurabh and Dr. Hamidi to come back on stage to felicitate the session. And to felicitate the session, it's my privilege to invite Dr. Sumit Goyal, Director and HOD of Neurosurgery, Group Director of Neurointerventional, Yatharth Hospital, to felicitate our chairpersons of last session. I'm requesting, sir, please come on stage, sir. Dr. Joseph Danny James. Dr. Gyan Saurabh. And Dr. Mohib Habidi. Thank you, sir. Our next session zooms into a unique trauma subset, injuries that affect both form and function. The topic is decoding limb crush injuries. For this, I need to call upon stage first our chairpersons, Dr. Sushma Sagar, Professor and Head, Department of Trauma, Surgery and Critical Care, AIIMS, New Delhi, Dr. Rajiv Thukral, Director, Orthopedics, Joint Replacement, Yatharth Hospital, Faridabad, Dr. Abhisar Katyar, Senior Consultant, Orthopedics and Joint Replacement, Yatharth Hospital, Greater Noida, Dr. Saurabh Kumar Gupta, Head, Department of Plastic Surgery, Yatharth Hospital, Greater Noida. Also, I'm requesting to please present to welcome our Chief Speaker, Dr. Veda Chigurupati, Assistant Professor, Department of General Surgery, Sion Hospital, Mumbai. Dr. Chigurupati received her training at AIIMS Delhi and IMS BHU and brings rich experience in managing a wide spectrum of polytrauma and surgical emergencies. Her clinical focus lies in trauma care, emergency procedures, and critical care. Ma'am, please. Welcome, doctor.
Sir, ma'am, I would sincerely request our chairpersons to keep our comments short. We are running very, very late and some people have a flight, they have to leave. And audience, you have any questions, we will catch Veda off the floor, please. Let's speed up a little bit. Sorry, thank you.
Thank you, organizing team. Good afternoon, everyone. I'm Dr. Veda. Today I'll be talking about crush injuries of limbs, their mechanisms, assessment, and management. Let us begin with understanding the definition of a crush injury. It is an injury caused as a result of direct physical crushing of muscles due to something heavy. It leads to a series of metabolic changes that is produced due to the disruption of the cellular integrity of the skeletal muscles and release of their contents into the circulation. These series of metabolic changes together is known as crush syndrome. Crush injuries can be closed or open like this. Crush injuries are relatively rare in civilian settings. However, in disaster settings like earthquakes or structural collapses, the incidence can be up to 15%. And the most important thing is the mortality is up to 48% when the patient develops crush syndrome. Most common mechanism leading to crush injuries are building or structural collapse, fall of heavy objects, railway accidents, run over by vehicles, or being crushed in between or inside the vehicles. Whenever a muscle cell gets crushed, it releases its intracellular contents like myoglobin, potassium, phosphate, and acidic metabolites like lactic acid, uric acid, and enzymes like creatinine phosphate and LDH into circulation. This leads to a series of systemic complications like myoglobin. It gets deposited in the renal tubules, leading to acute tubular necrosis, which further leads to acute kidney injury. And sudden increase in the serum potassium level can precipitate cardiac arrhythmias, which can include asystole. Potassium phosphate, when it released excessively into the circulation, binds with calcium and leads to hypokalemia. And all the acidic metabolites can lead to metabolic acidosis. Apart from this necrosis of myocytes, whenever there is a crush injury, there is an occlusion of macro and micro circulation, which leads to regional ischemia. This regional ischemia makes the cells and the capillaries leaky. And when the compressive force is released and blood flow is restored to that previously ischemic tissue, it leads to something called a reperfusion injury. That is, whenever the blood flow is restored to the ischemic region, previously ischemic region, because of the capillary leaky capillaries, there is influx of sodium, calcium, and other fluids into the muscle cells, leading to compartment syndrome, which further compromises the circulation and leads to further muscle necrosis and further release of myoglobin and AKI. And not only this, when the circulation is restored to the ischemic tissues, the toxic metabolites which have accumulated in the ischemic tissue are brought back into the circulation. And this regional ischemia will lead to an activation of nitric oxide system, which leads to vasodilatation and hypotension, which will aggravate the AKI. So this is basically the muscles get crushed, which releases enzymes, and the capillaries also get damaged. They become leaky, which leads to shift of fluid into the third space. Both this myoglobin and the hypovolemia will further lead to AKI. So we must understand this crush injury is not just a local injury to the muscle, but it is a systemic complication. In India, we rarely get a chance to intervene in the pre-hospital settings, but whenever you get a chance to intervene, we must start resuscitating these crush injury patients in the field itself. And we must ensure that these patients are shifted to higher level trauma centers where dialysis facilities are available. And when such patients are received in ED, we must follow ATLS protocol and do a primary survey and start crystalloid resuscitation. If the patient is in refractory shock, we must shift such patients to immediate exploration and consider amputation if required. Always we must value life over limb. But if the patient is hemodynamically stable, we proceed to secondary survey. During secondary survey of a patient with crush injury, our aim should be identify if the patient is developing a crush syndrome, whether the limb is viable or not, and whether the limb is salvageable or not. So how do we recognize that the patient is developing crush syndrome? It can be done either by clinical findings or certain biochemical parameters. Coming to the clinical findings, the local examination of the limb, especially in a closed crush injury, will show 6 P's of compartment syndrome, that is pain, pressure, paresthesia, paralysis, pallor, and pulselessness. And certain systemic features can also be identified, like dirty brownish discoloration of the urine and profound hypovolemic shock. And the biochemical parameters which help us diagnose crush syndrome are urine for myoglobin, serum myoglobin, muscle enzymes like creatinine kinase, and severe metabolic acidosis, raised urea, creatinine, and raised potassium, serum potassium. Urine for myoglobin is a quick and easy test. But it becomes positive only after serum myoglobin reaches certain renal threshold. So it will take some time for it to become positive. and it is mostly used in disaster situations, and it can be positive in hematuria also, so it is not a very specific test. Serum creatinine kinase is the fastest and the cheapest test that is available, but it becomes positive only after 2 to 12 hours, and the serum creatinine kinase levels, they remain positive for at least 1 to 3 days. And it is the most sensitive test to identify muscle injury, but it is not a very good predictor of AKI. Because it will take certain time to become positive. Serum myoglobin is the first test to become positive. It usually raises within first 3 hours of injury, and it peaks within 5 to 10 hours. And it has very short half-life, and the serum myoglobin is cleared of the circulation within 24 hours. And it is the best predictor for AKI. Not only serum myoglobin, admission transaminases level more than 1000, or the initial VBG showing a bicarb concentration of less than 17 millimoles per liter are also very good indicators to predict myoglobin-induced AKI. So how do we treat it? Our main aim while treating a crush syndrome is to prevent AKI. For that, we use a three-pronged approach. One is to do a volume resuscitation and repletion, 2, systemic alkalinization, and 3, diuresis. The choice of fluid for volume resuscitation is isotonic normal saline. We initiate fluid at the rate of 1 liter per hour. We can reduce it to 500 ml per hour after 2 hours. Once the patient receives at least 6 liters of fluid, then we will start assessing the volume status of the patient and the urine output. Our urine output target is 300 ml per hour. So after receiving 6 liters of fluid, if the patient is anuric, only then we'll reduce the flow rate to just the replacement value plus 1 liter. But if the patient is producing adequate urine output and he is not in cardiac failure or elderly, we'll continue the resuscitation at the same rate, at 6 liters per day. For systemic alkalinization, sodium bicarbonate infusions are started at 200 to 300 milliequivalents per day. It will reduce both metabolic acidosis and also hyperkalemia. And alkalinizing the urine to a pH of more than 6.5 will prevent renal tubular deposition of myoglobin and AKI development. For diuresis, mannitol is used. We initiate mannitol, 20% of mannitol, we give a test dose of 60 ml over 3 to 5 minutes. If the urine output is increased by at least 30 to 50 ml per hour above the baseline, we'll add mannitol to the treatment chart at a rate of 1 to 2 grams per kg per day. If after the initial mannitol test, if there is no increase in urine output, mannitol should be discontinued. Even after correcting the hypovolemia, the patient is anuric, we'll restrict the fluid to 1 liter per day plus losses of previous day, and we must avoid further nephrotoxic drugs and maintain fluid electrolyte balance and acid-base balance, and we should consider early hemodialysis in patients of crush injuries. And these patients, they usually require more frequent dialysis than other causes of AKI. And apart from this, we must also correct the hyperkalemia, we must take care of pain control and prophylactic antibiotics, and these patients also require continuous ECG monitoring because the hyperkalemia can cause cardiac arrhythmias. Now that we understood the management of crush syndrome, let us discuss briefly about the management of the crushed limb per se. The management mainly depends on the viability of the limb and the salvageability of the limb and whether or not the patient has developed compartment syndrome and the systemic condition of the patient. So if a limb is cold and insensate, then we consider it to be non-viable and we proceed with amputation. But if the limb is warm and there are sensations are intact, the management depends on whether it is a closed crush injury or a mangled extremity. If it is a closed crush injury, we'll look for any signs of vascular injury. If there are signs of vascular injury, we do a CT angio and proceed accordingly. But if there are no signs of vascular injury, we look for signs of compartment syndrome. If the patient has developed compartment syndrome or impending compartment syndrome, we do fasciotomy and then proceed accordingly. If there is no signs of compartment syndrome also, we continue to monitor these patients very closely. And if there are any associated fractures, we get an orthopedic review. If the crushed injury is a mangled extremity, we must assess the viability. We have already confirmed the viability of the limb, then we'll assess the salvageability of the limb. For this, we use certain scores. And actually, assessing the salvageability, that is whether the soft tissue injury is repairable or not, is the most crucial and difficult step in management of crush injuries. There are several scores proposed to predict the salvageability of this limb, but there is no one ideal score. The problem with these scores are low scores usually they predict the salvageability potential of the limb, but the high scores doesn't always mean that these patients require amputation. MES score is the most commonly used score. Historically, it includes four parameters. One is skeletal or soft tissue injuries, limb ischemia, whether or not the patient is in shock, and the age of the patient. And usually scores, MES score more than 7, the limb is considered to be non-salvageable and will usually advocate amputation in such cases. But with the advancements in damage control principles and balanced resuscitation and increased use of vascular shunts which reduce the ischemic time, doing early fasciotomies, improvements in wound care and microsurgical abilities and advanced usage of advanced tissue coverage techniques, the predictability of the MES score has come down. Previously, the limbs which were used to undergo amputation have now become salvageable with these advancements in both resuscitation and wound care. Another most commonly used score is a Ganga Hospital Open Injury Severity Score. It is specifically proposed for grade 3 tibial fractures, grade 3B tibial fractures, that is open fracture with vascular injuries. It takes into consideration the skin loss and the soft tissue injury, bony injury, and additional risk factors. Score of less than 14 is usually considered salvageable, and score of more than 17 is considered for amputation. But the score of 15 to 16 is a gray area where you have to decide on case-to-case basis. These scores, what we must understand is these scores, they are just a guide. They are not an absolute indications for amputations. So in practice, we generally take into consideration these following factors like warm ischemia time. Usually if it is more than 6 hours, the outcomes of the vascular repair are not really great and there is an increased risk of reperfusion injury. So in our practice, we generally don't prefer revascularizing beyond 6 hours. And the extent of soft tissue loss is also a very significant factor because this soft tissue injury gradually evolves. I mean, the muscles which appear viable on the initial debridement may not be viable on the second day or third day. So your treatment plan must also change according to the progression of the soft tissue injury. And coming to the skeletal and neurovascular injury status, if the bone loss is more than 4 centimeters, it is usually very difficult to reconstruct. And similarly, there are associated nerve injuries. In the repair of nerves in the crush injuries is usually not advocated because the field is usually generally very contaminated. And most of the times, the nerve injuries, there is no structural disruption is not there. It is just the blunt force that is transmitted into the nerve, which has caused some neuropraxia or something, which the nerve may or may not recover. So the functional outcomes, if there is an associated nerve injury, is difficult to predict. And patient's physiology must also be taken into consideration while planning the salvageability or the reconstruction of the limb, because if we venture on doing prolonged reconstruction of the limb in a hemodynamically unstable patients, it may actually have a adverse counterproductive effect. And we must also take into consideration the occupation of the patient so that we can understand how much mobility the patient might need. And if you are salvaging a limb which is not very functional, may not be really useful for patients whose occupation is such that they have to be mobile. So salvage versus amputation basically depends on 3 variables, that is patient factors, injury factors, and the surgeon factors. Patient factors and injury factors are something which we cannot control, but surgeon factors are more or less modifiable. So if we consider, if our center or if our skill set is not enough to manage or to meet all the requirements of the patient, we must consider early referral of such patients. So once we assess the salvageability of the limb, if we think the limb is not salvageable, we must go for primary amputation. But if we consider the limb or the soft tissue injury to be reconstructible, we must assess if there is any suspicion of vascular injury or not. If there is a suspicion of vascular injury, we must get a CT angiography and then proceed accordingly. Otherwise, we must take up those patients for debridement plus minus external fixation, depending whether there is a fracture or not. So the aim during debridement must be, we should make the wound free of all the contaminants, and all the tissue that is left after debridement should be viable. It should be ideally done under anesthesia and under tourniquet application in adequate lighting and magnification by an experienced surgeon. So during debridement, we must freshen the skin margins and then subcutaneous tissue till a bright yellow normal looking fat is seen. And if we are doing it under tourniquet, the normal muscles appear pale, but they are homogeneous, and the non-viable muscles appear heterogeneous. And those bony fragments without any soft tissue cover should also be removed. And the longitudinal structures like tendons, nerves, and vessels, if they are intact, we must preserve them. So even after salvaging the limb, sometimes the patient might come back to us with limb dysfunction or persistent wounds and persistent infections or chronic pain. These are also late indications for amputation. This is a case which has presented to our ED recently, in which we have successfully salvaged the limb. This is the initial presentation and after first debridement. And this is the second day after debridement. After second debridement, we can see the entire tibia is exposed. In this case, we have used the dermal template to cover the tibia or the exposed bone, and allograft for partial wound cover. And NPWT was applied over it. Eventually, we have serially grafted the entire limb. Thank you.
Thank you, Veeda, for a wonderful presentation.
Thank you.
1 or 2 tips you want to give to the residents who are sitting here? Yes, key points from your end. If they get a crush injury patient in their emergency in the middle of the night, what are 1 or 2 things they have to do and what they should not do?
First thing is you should do wound wash as early as possible in the ED itself. And you should not miss vascular injuries. You should specifically look for the vascular status of the limb so that early revascularization can be done.
Okay, I just had to add here. Interestingly, you are doing your MCH right now or you finished?
I've finished.
Okay, so I'm from the same institute as where you are right now. I've done my master's from Sion, and we had the first trauma center in probably India, way back 1999. Anyways, the point here I'm trying to make is that 3 factors actually decide, you said. One is patient factors, very important, because older patients, younger patients, unfit patients, unsick patients will change the prognosis. Second is injury factors, so what kind of injury you have to the skin, soft tissues, vessels, etc. And the third is what you have at your disposal, the resource factors. So understand that if your center is not equipped, you don't have backup of a plastic surgeon, a vascular surgeon, do not attempt to treat these patients, refer them quickly. You have a golden hour for life saving, you also have some 6-hour period for limb saving. That's my little 2 cents.
A very good presentation. Actually, you covered everything into it. You have not left out anything. And needless to say that crush injuries do play a very important role in treating this because they are the patients who need the utmost attention to all of us. anything missed out at any point of time can lead to a damage a patient will never recover from it. So as you rightly pointed out, vascular injuries should always be assessed. Plus, if you don't have adequate facilities for such thing, please don't do a heroic attempt at doing it on your own self in which you are not equipped. So the most important takeaway point is don't attempt anything that you are not capable of doing it. Let the master or the person who is more capable of, let him do that job. Please don't do it on your own self. Treat as much as you can. That's it.
Nice presentation, Dr. Veda. I just want to know your opinion regarding Gustlow-Anderson type 3B injuries. Would you like to try for the primary cover, or you would like to serially debride it accordingly and then take later on for the cover?
Open fractures.
Yeah, open fracture with periosteal stripping. So, and it is contaminated. So, would you like to cover it in the primary stage, or would you like to debride it serially and then cover it? Because it is a catch. The bone is exposed.
Yes, sir. In our practice, generally we do serial debridement, and we try to cover the wound as early as possible, but not on the initial debridement day.
Okay, thank you.
Not on the first day one.
Thank you so much, Dr. Veda. To felicitate our chairpersons, I am requesting Dr. Gunjan Kishore Sharma, Senior Consultant, Internal Medicine Department, Yatharth Hospital, Greater Noida, to come forward and please felicitate our chairpersons. Before that, I am requesting Dr. Sushma Sagar to felicitate your student, Dr. Veda. First, we have Dr. Sushma Sagar. Dr. Rajiv Thukral. Dr. Abhisar Katyar. And Dr. Saurabh Kumar Gupta.
Thank you so much. We now begin what promises to be one of the most dynamic sessions of the day, a panel discussion that brings together multidisciplinary brilliance and frontline trauma management. Our topic, multidisciplinary mastery in trauma, a panel that saves lives. This will be a captivating discussion on actual polytrauma scenarios. Our panelists include Dr. Parul Isar, HOD Critical Care Department, Yatharth Hospital. Dr. Parul Isar is a highly accomplished medical professional with MBBS and MD in anesthesia, currently serving as the head of the Critical Care Department at Yatharth Super Speciality Hospital. With a distinguished career spanning over 2 decades, Dr. Isar has extensive 15 years of experience in critical care and trauma, pain management, ventilatory strategies, infection, sepsis, and end-of-life care. Recognized with the Swami Rama Gold Medal for Academic Excellence, Dr. Isar has published numerous research papers and actively participates in national and international conferences. Passionate about education, Dr. Isar is dedicated to training the next generation
of medical professionals. Under her leadership, Yatharth Super Speciality Hospital has started DNB program as well.
Dr. Sandeep Jain, Director and Head Department of Emergency and Trauma, Sharda Care, Delhi. Dr. Jain is a seasoned emergency and trauma specialist with 24 years of experience, proficient in advanced resuscitation and life-saving surgeries, and has led emergency medicine department for 16 years.
Next we have Dr. Amit Gupta, Professor, Trauma Surgery and Critical Care, JPN Apex Trauma Center. Welcome, Dr. Parul Isar. I'm requesting Dr. Sandeep Jain to come on stage and join us. Dr. Amit Gupta, Professor, Trauma Surgery and Critical Care, JPN Apex Trauma Center, AIIMS, New Delhi. Professor Dr. Amit Gupta is a leading authority in trauma care, currently serving as professor at the Division of Trauma Surgery and Critical Care at JPN Apex Trauma Center, AIIMS, New Delhi. He is the chairman of the Asian Collaboration of Trauma, ACT, and founder, honorary secretary, and executive member of the Indian Society for Trauma and Acute Care, STAC. He also chairs the Academy of ACT. A distinguished academic, Dr. Gupta is a fellow of the Royal College of Physicians and Surgeons of the Glasgow, fellow of the American College of Surgeons, FCLS and FAACT. He has held visiting faculty and fellowships at prestigious trauma centers in the USA, Australia, and Israel. With over 2 decades of research experience and 150 plus publications, his key interests include trauma system, injury epidemiology, trauma critical care, and quality improvement in trauma care.
Next panelist, Dr. Kaushal Kant Mishra, Director, Department of Orthopedics, Fortis, Okhla, with over 20.
Sorry for the last minute change, everyone. Can I please request Dr. Rajiv Thukral to please join us on stage again? We would love to hear your opinions on the panel, sir. Next, Dr. Mohib Hamidi, the Director of General Surgery in Yatharth Hospital, Greater Noida. Sir, please join the panel and enlighten us.
Dr. Manish Bharti, Senior Consultant and HOD Critical Care Medicine, Yatharth Hospital. Dr. Bharti holds postgraduate degree from Maulana Azad Medical College, Delhi, and an FNB DNB Super Speciality in Critical Care from Indraprasth Apollo Hospital. He has over 10 years of dedicated experience and is an ACLS instructor, an active member of ISCCM, ESICM, and ISA Society. Let's now immerse ourselves in cases that challenge, inspire, and profoundly remind us what it takes to save a life across specialty. Over to Dr. Parul Isar. From here, Dr. Parul will guide you through.
A very warm welcome to all the panelists. And this session particularly belongs to all the residents who are present here. And believe me, this is going to be a golden opportunity for all of you to extract as much knowledge and information possible from not only the learned and experienced panelists over here, but all the esteemed and experienced faculty as well, who is sitting as an audience with us. So we will be beginning with our panel discussion. To make it more realistic and less hypothetical, we have actually transformed into a case-based discussion. We'll be going through various real-time experiences of ours, and we'll see how our expert and learned panelists would have faced these cases, and they will give us an insight on the best way to handle such kind of trauma cases.
I apologize for a lot of logistic issues in the most interesting session. Please give us a minute. Sincere apologies.
Any issues? What happened? Acha, slides?
Yeah, so the hall is actually open to the questions. Any question from the previous sessions which we have had during the day so far? Anything which you want to ask, not only to the people sitting in the panel, to the audience as well? Residents?
If they have no questions, now you ask questions now.
Okay, so
let's
presentation is here.
Have a check.
So let's quickly start with first case. He was a 27-year-old male who was riding a two-wheeler with helmet put on, but he was unfortunately hit by a four-wheeler, and then he was run over by another four-wheeler. He arrived in the ER within 1.5 hours of injury. That means the golden hour was lost. Quickly on the primary survey, the ER team found that his airway was patent, cervical spine was stabilized with C spine collar, breathing was spontaneous with respiratory rate 20 to 23 per minute, saturation was well within the normal range, CCT was negative, and bilateral air entry was equal on both sides. But his systolic blood pressure was only 88 millimeters of mercury with tachycardia, a heart rate around 148 per minute, and his fast was positive. Along with the fast positive, quickly during the primary survey itself, we noticed that his right lower limb was badly crushed, and there were multiple fractures on right femur. There was a fracture which was open involving both bones leg, plus there was oozing from his open wounds as well. He was found to have palpable femoral pulse on right side, but popliteal, DPA, ATA and PTA were not palpable on right side. On left side also only femoral pulse was palpable. But abdomen was soft, non-tender, non-distended. 1 liter crystalloid bolus was given and he was a non-responder. Immediately massive hemorrhage protocol transfusion was started. GCS was 15/15 and his pupils were bilaterally reactive. When we talk of bedside adjuncts, we did a chest x-ray which did not reveal anything significant, and a x-ray pelvis was also done, and as I mentioned earlier, his fast was positive in hepatorenal pouch. Blood gases were alarming. They showed severe metabolic acidosis with pH of only 6.8 and very high lactate levels, 16.7. Base deficit was incalculable, though hemoglobin was in a range of 10.8. These are some of the images which we have from that patient, and you can see there were multiple open injuries which were revealing the inside fractures as well, and there are corresponding X-rays which show the bony injuries inside those open wounds. Now my first question goes to Dr. Sandeep Jain from the ER. Sir, how will you approach to this patient as soon as he arrives in the ER?
Yeah, so your patient has come to us with a polytrauma, and obviously if you look at the primary survey, which is ABCD, his airway was clear, he was conscious with GCS of 15/15. Respiration was okay with a rate of 23, but air entry was equal and saturation was maintained. Obviously this patient had a hemorrhagic shock. Patient BP is low and tachycardia is there. If you look at this, you have given the fluids. Even after the fluids, it's a non-responder. So this patient requires an urgent OR. Obviously, you've done a fast which shows the hepatorenal pouch was positive for the free fluid. So this patient obviously is bleeding somewhere inside. So what in the emergency you should be doing is, one is that you have to activate your massive transfusion protocol. You have to ensure that the patient's wound is covered, just a quick wash and cover, that's all. And you have to put 2 wide bore IV lines. You have to start giving the fluids, start your massive transfusion protocol. Since your patient has also come within 1.5 hours, so a dose of tranexamic acid has to be given. And don't forget to maintain the patient's temperatures. So hypothermia in this patient will be very deleterious. So as it's been done, the first thing in the ER would be to call the trauma team, call the trauma surgeon or general surgeon who handles this, and let the patient be taken to the OR without any further investigations.
Thank you, sir. So after quick initial resuscitation, we saw that the patient was non-responder, and after massive hemorrhage protocol also initiated, we did the gases. The gases showed severe metabolic acidosis, but as the appropriate ER management was done, we would like to ask the orthopedic surgeon, Dr. Rajiv Thukral, what would you do when you look at such kind of an orthopedic injury in the ER?
So the good news about being an orthopedic surgeon is that we come into the picture last.
What if you were called in the
But
ER? Because,
yeah.
sorry to interrupt you. So what we practice at Yatharth is a code trauma. As soon as the polytrauma patient arrives, we announce code trauma, and whoever is a part of the trauma team immediately tries to rush to the ER, including the ortho team.
Yeah.
So that's why the question went to you.
So I can tell you what we would do immediately. For example, we'll obviously do a nice packing of whatever open wounds are, locate any site of bleeding and sort of stop that bleeding, and then splint this limb, either in a Thomas, like it has been put in a Thomas splint like that, or give traction in such a way that for the time being, the attention goes away from the limb and we look at the rest of the body. Because this cannot kill him. But if he has an abdominal injury, that can kill him. So the surgeon comes into play, and if he says, okay, this is fine, then we come into play. Otherwise, the emergency trauma team will take care of the resuscitation, will take care of the IV fluids, will take care of the base excess and the bicarbonate. There is less, the acidosis, because unfortunately, most of the ortho surgeons are not well equipped to handle that on their own. So we need them, right? So once they say, okay, now you go ahead, then we go to definitive surgery. That's how we would manage. This is practical what we do.
Thank you. So initial ER resuscitation done, orthopedic stabilization, hemostasis done as far as possible in the ER. Now next, the general surgeon is pitched in. Dr. Mohib Hamidi sir, will you please let us know how should a surgeon approach to such patient who had positive fast with blood in hepatorenal pouch, non-responder to initial resuscitation, and still showing blood gases towards severe metabolic acidosis?
First, we have to resuscitate the patient, and in the abdominal injury is not much. There's minor fluid in the renal recess. So we will manage him conservatively, and if hemoperitoneum increase, then we'll go in and we'll do the surgery, or we can do a diagnostic laparoscopy and see whether he has got any other injury or not.
All right. So now let's go to the real case scenario, what happened actually in this patient. So after a discussion with the relevant involved multi-specialities, the patient was taken to the CT room for CT angiography right lower limb, along with CT abdomen, with blood on flow of course, and inotropes had to be started in the CT room because patient started showing non-responding hypertension. CT showed cutoff at anterior tibial artery with liver laceration in segment 7 and 8 and moderate hemoperitoneum. Patient was quickly shifted to OR with a plan for external fixation of right lower limb, hemostasis and laparotomy. But unfortunately, on way to OR, patient arrested, and even before commencing the surgery, patient died. We lost this patient. Now my next question goes to Dr. Manish Bharti. Sir, would you like to give us some insight on what actually went wrong in this patient?
First of all, thank you, Dr. Parul. Meeting to you for the first time. Heard a lot of good news for you.
My pleasure, sir.
And at the outset, I would like to express my gratitude to Dr. Farah, Dr. Shefali for bringing me here and allowing me to express my views onto the trauma resuscitation. There are just some things I would like to add, Dr. Parul. When the patient is coming to you, let's say in a 1.5 hours, because a lot of people are students in the group, it's not necessarily the 1 hour which you have to talk about for the golden hour. The golden hour is basically the concept where you have the opportunity to make a maximal impact onto the patient outcome. So irrespective of whenever the patient is going to come, that the first hour interaction which you are going to interact with your patient is something is very, very crucial and very, very important. In a trauma scenario, the cause of shock is hemorrhage, hemorrhage, and hemorrhage. So the management of the hemorrhage has to be taken into the consideration, which means although we have seen airway looks open, the breathing has been taken care of. You said that the MTP protocol, massive transfusion protocol, has been activated, but we also need to know how much blood component has been transfused to the patient, right? Many of the time, the delivery or the execution of the transfusion becomes the issue. So we do believe that the patient has received the transfusion, but then making sure as an intensivist, as a resuscitator, that actually the transfusion is happening with the patient. That is one. The second point, which you said about the metabolic acidemia, right? So obviously the cause of metabolic acidemia in this case is hypoperfusion because of the hemorrhagic shock. I don't know whether this kind of a case can be taken up for the OT, the OR, although yes, the patient has been taken up with the ongoing resuscitation. But if your patient is having a pH of 6.8, and if I don't know that the patient has received whether the adequate amount of the resuscitation in the form of blood, in the form of the correction factors like metabolic acidemia, I'm not sure whether this patient is going to handle the brunt of the surgery. And possibly that's why, it's a difficult case. There is no doubt it's a difficult case. So let's not go by that something which we have missed. But 6.8 pH on the OT table, induction with your sedatives and hypnotics, whatever the drugs come, your patient is come to the event. So I think that's all which I can contribute to this case. Difficult case, by the way.
Thank you, Dr. Manish. So in the end, Dr. Amit Gupta, sir, I would like to request you to please give us an insight on what went wrong in this case and what would have been a better plan of management so as to avoid this fatality.
Thank you, Parul. Thank you, Shefali, and all the organizers, first of all, for having invited me for this really wonderful session. This is the most active session probably, or is going to be. So I think coming on to the case itself, I had noted down certain points which were very, which were looking at my face. The first one was obviously after injury, the patient arrived in your ED in extremis, right? So he's definitely in shock. And if I see the ABG, even before the ABG, I could gather that he was in what is known as class 4 hemorrhagic shock, right? And we always say that the treatment of hemorrhagic shock, so there's a difference between managing hemorrhagic shock and treating hemorrhagic shock. Now, managing hemorrhagic shock is DCR in the ED, right, which would include what Dr. Sandeep and Dr. Manish rightly said, the massive hemorrhage protocol initiation, IV lines, warm crystalloids, which were already given, maybe tranexamic acid because he came within 3 hours, maybe maintaining a sort of a low level of blood pressure or MAP, which is known as permissive hypotension. All that was probably done in the ER. But the treatment of hemorrhagic shock is hemorrhage control, right?
And that's why C in trauma is not only circulation, but it is circulation with hemorrhage control. So all the focus of anybody in the emergency department or of the treating trauma surgeon should be to find out where is he bleeding, where is he bleeding, where is he bleeding, right? Now, it's very clear from the initial adjuncts to primary survey that probably he's not bleeding into the chest. So the sources of bleeding, exsanguinating hemorrhage are 1 on the floor and 4 more. We all know that. And the 4 more are the cavitatory bleeds, which are either chest or the abdomen or the pelvis and retroperitoneum in pelvic fractures or the extremities, right? And extremities would obviously be what the extremities were looking like, and probably he might have lost a lot of blood because both the sides arteries were not palpable beyond, say, popliteal, or in one case probably beyond the femoral. But there was no ongoing bleed then, so probably Dr. Tokral was right that he would probably like to control it by compression bandage and some splinting initially in the ED, which was done. But what was startling was that there was also fast positive. Now, fast positive in an unstable patient means that some amount of hemorrhage has already taken place inside the abdomen. This patient needs to go to the OR. No questions asked, right? I am perplexed by the decision of taking this patient on flow blood with class 4 hemorrhagic shock with a pH of 6.8 to the CT room. Now, we always say in trauma that CT is the graveyard of trauma patients, primarily because we don't understand. We lose a lot of time in the CT scanner. Now, what additional did we get from this CT that would have changed our management, right? So, was it the CT angios? Because it would have taken minimum of 15 to 20 minutes, even if you have the best CT scan and the radiologist available. It would have taken about 15 to 20 minutes in the CT room, where he actually collapsed and you had to start the inotropes. I would say that you already have a fact that external hemorrhage has been controlled. There is some indication that there is an internal hemorrhage going on. You have to take him to the OR and at least explore and arrest that hemorrhage. What was the worst case scenario? Worst case scenario would have been that you do not find any hemorrhage or major hemorrhage source in the abdomen, but liver laceration could have been packed. You could have been sure that, okay, now he is not bleeding anywhere. We need to continue the resuscitation, take him to the ICU, and then manage it in the ICU. So I think simply damage control resuscitation, and the surgery is a part of damage control resuscitation itself, would have been probably a better choice. I don't know whether it would have made a difference in the final outcome or not. It all depended upon how much blood he had lost already, and which was in excess of 2.5 liters probably, and how much blood he got actually. But definitely hemorrhage control should be our goal if we see a patient in extremis. That's my view of it.
Thank you, sir. I totally agree with you. As we learned in the morning session as well, that CT is a part of secondary survey and not the primary survey, and any hemodynamic instability rules out the CT scan. So it is not a priority to get the CT scan in an unstable patient. Instead, the patient should have been ideally shifted to the OR. So take-home message from this case is that CT should be a part of secondary survey after stabilization of the patient. And the only requisite is a hemodynamically stable patient. Only then the patient should go to the CT room. Thank you. The next case is a 54-year-old male who was ran over by a tractor over his lower torso. The time of arrival was within 1 hour of injury. The airway was threatened in view of severe shock, so he was intubated. His C-spine was stabilized, and he was put on mechanical ventilation. CCT was negative, and bilateral air entry was equal. His systolic blood pressure was again 62 millimeters of mercury with severe tachycardia. PCT was fast was positive as well. He was also non-responder. Massive hemorrhage protocol was started immediately. His pupils were bilaterally reacting. In bedside adjuncts, we did an X-ray chest, which did not reveal any major significant abnormality. But yes, pelvis was fractured, and it could be easily made out on a X-ray pelvis. I'll repeat, fast was positive, and patient had hematuria. There was blood in Foley's. Blood gases were again indicative of metabolic acidosis, high lactate levels, severe base deficit. Hemoglobin was again lingering around 11.6. So we are again dealing with a polytrauma patient. probably fracture pelvis this time, again a non-responder. So straight to Dr. Amit Gupta sir this time. Sir, how would you approach to this patient now?
Okay, so this case basically was in again extremis with a so we'll have to look at the fracture pelvis, and what I am seeing actually is that probably he had a vertical shear sort of a fracture, which is open book. It's an open book fracture. In any case, so yes, any unstable patient hemodynamically with an unstable pelvic fracture would in the ED require some sort of a circumferential compression device. And most commonly we use pelvic binder. So the first line of treatment would be to use a pelvic binder in this particular case. And then obviously initiate, because he is in class 4 hemorrhagic shock, again initiate the DCR and all the components of DCR therein, including MHP, which you had already done probably, and then look for now what the response is after the pelvic binder has been applied. Anybody else?
Anybody would like to add anything?
This is one of those few orthopedic emergencies.
Correct.
One of those two. There's just two.
So damage control resuscitation was done, pelvic binding was done, massive hemorrhage protocol was also initiated, and he was a non-responder. Now what, Dr. Rajiv Thukral?
So, like rushing to the OT and doing an exploratory lab, we do a pelvic fixator right there in the emergency. We put pins, we call for the stuff from the OT, and we do it under local anesthesia. So we get compression of the pelvis, and we close down that open space. And then, of course, we have to allow and check and see whether there's any additional cause of the bleed. For example, a venous bleed inside the pelvis or an organ injury inside the pelvis. So once the patient is stabilized after the pelvic fixator,
so we can do pelvis fixation
we
in
can
an
do
unstable
it in the
patient.
emergency, no problem.
We can do it
easily, no
so
problem.
Pelvic fixation is a kind of damage control
So
surgery.
it's pure damage control orthopedics.
Okay.
Yeah. For example, pelvic binder first. If that doesn't help, fixator straight away.
Okay. So the patient was taken to the OR as suggested by Dr. Rajiv as well for damage control surgery with, of course, blood on flow. OT findings, I would actually like to invite Dr. Shefali here. Where are you, Dr. Shefali? Because she was the operating surgeon and she would be the best person to give an insight on detailed findings which she found on the OT table.
So before I actually divulge into the operative findings, I just have a humble submission, Rajiv sir. I don't know, in trauma center we have not learned this practice of using a X-fix for damage control. You are absolutely right, it is a damage control procedure. But recent AST guidelines all say that a pelvic binder is as good as an external fixator. So we did apply it, and since he was grossly fast positive, we were concerned about intra-abdominal bleeding also. So we proceeded with damage control surgery. So I would just, for the residents, I would not like to give this message that a pelvic non-responder straight away go for X-fix. No, it varies case to case, and you have to evaluate every case.
I'll just clarify what I was saying. I never said that a pelvic binder wouldn't work. I just said that if you need to do even better stabilization, when you're going to the OT, a pelvic binder has to be opened for the surgeon to take care. So within 10-15 minutes, you have to put a fixator in place so that the surgeons can proceed.
I think there, Shefali, I would slightly, because you're already taking this patient to the OR. Now, external fixator of the pelvis would be required in any case, so as to skeletally stabilize the pelvis. So it has to be hand in hand, a part of the damage control. They would put in the pin, obviously not put the crossbar initially, so that you can operate inferiorly, or so that you can operate, arrest the hemorrhage, pack the pelvis if required, or maybe even do an internal iliac ligation, pre-pelvic. This patient already had hematuria. This patient had a dome of bladder rupture, so you would repair that. You take some amount of time for hemorrhage control and contamination control. Let them put a pin simultaneously. I'm not saying only exclusively. No, not exclusively. Up as a part of the procedure, and then before you take the patient to the ICU, I mean hemorrhage control, then you apply probably the crossbar and then take him, so that his pelvis does not move.
Right. So in OR, he had gross hemoperitoneum. His bladder dome was in pieces. Also, he had a neck transaction completely. His left iliac vein was transected, which was ligated. And there was an abdominal wall internal degloving injury. So I am quite a young trauma surgeon. This is the first abdomen I opened when everything was in layers. I opened the skin, sheath, everything was just separated from each other. It was massive, bad degloving injury. So, next slide. So in that setting, since the patient was in extremis, we did damage control surgery. Pelvis was packed, the vein was ligated. Only skin-only closure was done, and this bladder injury was quite complicated to be reconstructed at that point of time. So it was Foley's was left in situ. Bilateral PCN was placed for urinary drainage, and I must appreciate the radiologist, Dr. Iqbal, is not here. Putting a PCN in a non-dilated system is no easy task, but he did that in that setting. So PCN was placed, and this whole procedure was done in 50 minutes, and he was shifted back to Parul ma'am for further resuscitation.
So the patient was shifted to the ICU for further stabilization.
Dr. Parul,
yeah.
can I?
Sorry.
In this case, alone pelvic binder or X-fix is going to worsen the situation, because if you see, this is a very beyond class 3 pelvis fracture. It is not just open book. It's a complex pelvis, posterior as well as anterior. If we put binder or X-fix alone, patient is going to bleed furthermore to death. So what should be done here is one should avoid pelvic binder. This is one more contraindication of pelvic injury. Perfect. Do a bilateral posterior SI joint fixation percute, which will take hardly 5 or 10 minutes each on either side, and then do anterior fixator. Otherwise, this patient will bleed to death. This is rather going to make injury more worse.
But you know, the beautiful part is you know about this only after the CT scan. You don't know about this till the X-ray.
I could make out on X-ray also. I was too, but then see, you can go back to X-ray. Bilateral SI joints are open, okay, and that shows that posterior injury is much more complex. I am not worried about anterior. I am not going to think about pelvic, but pre-peritoneal pelvic packing is good enough. And anyway, you are going to do laparotomy, so you can do bilateral internal ligation as well. But if you are not fixing the posterior portion, it is going to be a disaster.
Case pelvic fixation is going to be quite a discussion in this. You'll see in the subsequent pictures. So the anterior skin was so bad you cannot place any pin anteriorly, and posteriorly at that point was not an option for us. Yeah, that was. And there is subsequent, you'll see in subsequent pictures, this was a really different case.
After 36 hours of ICU stay, after restoring his physiology, patient was taken to the OT for a relook surgery where removal of pack was planned. There, on the way to OT, we did a CT, and that is how we were able to actually visualize the extent of shattered pelvis. And then we were very happy with the decision of not touching the pelvis in the beginning.
I think, can I just add one point, Shefali? And I would agree with Dr. Shah when he says that the posterior injuries, because also they have some, well, this patient might not be having, but at times there is a degloving injury in the perineum itself. So what is happening is that the bleeding is happening and it is coming posteriorly and coming through the pelvis, the perineal floor. In that case, even packing at times does not work. These are difficult cases. This is not a run-of-the-mill normal pelvic fracture.
Agreed,
These are really, really difficult cases. I'm sure if you have saved this life, you've done a very, very good job, great job. But you're right that at that time, packing can be there, but if the bleeding is not controlled and in the ICU again within 24 hours, if he starts bleeding from the perineum once again, the only option left, as Dr. Shah said, just put in 2 pins or 2 screws in the posterior part so that at least some stability to the pelvis is given. That's all.
So during the relook surgery, the bladder repair was done, ureteric reimplantation was done, and the abdomen was closed. But on day 4, unfortunately, patient started showing signs of raised intra-abdominal pressure. So the abdominal sutures were again opened, and a mesh laparoscopy was made this time, and patient was again shifted back to the ICU. Patient obviously had infections. He started throwing high-grade fevers. His cultures started coming positive. Adequate antibiotic coverage was given. Antibiotics were stepped up. During the next coming days, repeated dressings were done on the bedside with adequate pain relief with the epidural analgesia, and slowly his wound started healing. There was little urine leakage as well from the abdominal wound in the beginning, but that also started reducing with time. But till then also we were not sure if we'll be able to send this patient back home? If at all we will be able to send him, then in what condition? Will we be able to allow him to sit ever again in his life? Forget about standing up and talking and walking. So slowly, the abdominal wound started healing. Eventually, skin grafting was done. This is the final look of the wound. There is
After
obvious
1.5
ventral hernia.
years, this patient.
There is an obvious ventral hernia which still needs to be repaired, but this patient was a true fighter, and that's why he's a survivor. And I would like to run this video for you just to show that in today's date, he's not only sitting, he's getting up, standing on his feet and walking. Can we please run this video? So this was no less than a miracle, and the only take-home message which we can get from this case is that patient has to live to fight another day. Instead of going for heroic day zero interventions, restoring anatomies, what is more important is damage control, resuscitation, and trying to focus on physiology restoration. If the patient is able to live that day, we will get many more days to make him live. And remember, physiology always comes above the anatomy. Case C was a
Parul,
30
can I just, because there are certain surgeons also sitting here, just a word to them. It might look very gory, it might look very non-physiological, non-anatomical, but laparostomas save life. And I've seen so many surgeons just closing up the abdomen without even thinking what effect that might have on the physiology. Just to give you an idea that an acute, a compartment syndrome of the abdomen can not only increase the compartment pressures of the abdomen leading to, say, renal failures, but it has a deleterious effect on thoracic pressures, which would increase the incidence of, say, ARDS or any other respiratory pathology. It also have deleterious effects on ICP. So through the venous channel and through the pressures, increase in the brain also, and therefore ACS is a life-threatening condition. Open the abdomen as soon as you feel that this patient is going down and he might have increased intra-abdominal pressures. This patient probably survived because the decision of opening up the abdomen and making a laparostoma was done timely. If not, probably he would have succumbed. I would like Manisha's opinion.
No, absolutely. You know, I loved, Dr. Amit, what you said. Just a couple of things, you know, from intensive care, because many of the time, you know, the surgeons and of course, you know, the orthopedician, they take the lead. But you also need to understand that this syndrome or intra-abdominal hypertension is a sequelae to something. And nowadays we call it as it's a disease which is partially a man-made, which means that if you over-resuscitate your patient, if you're giving them a lot of crystalloids, which we tend to happen, the moment somebody see that the lactates, they are high, the first reflex which any physician or maybe the respected surgeon will give a challenge. And that is not something which we encourage in modern intensive care. So what we say, especially Dr. Parul, in case if this patient was sedated and paralyzed, you have to assess the fluid responsiveness. I know many of you may not be from the intensive care, but you must understand in today's era, the fluid is taken as a drug. So there has to be an indication, there has to be dose, there has to be duration, there has to be de-exhalation, and there has to be de-resuscitation. So we call it as 7 Ds of therapy. So that is of primum importance because we see a lot of cases from the general surgery where, and you know, it's a belief system somehow that, you know, I remember my old days from my liver transplant, and the surgeon used to say, you have to swell to get well. That was the saying which used to be there in the past. And now we say you have to be lean to become mean. So this is the way we have changed. There is a complete paradigm shift. By the way, this patient was ventilated at that stage?
Yes, he was intubated right in the ER because he was in shock.
Yeah, so thank you, Dr. Parul. Another important thing, because surgeons, they approach it from directly like making a laparostoma, which Dr. Shefali has said. It's also a responsibility of the physician, the perioperative physician or a surgeon, to make sure that they're managing the intra-abdominal hypertension in medical ways as well. What do you mean by medical management? The patient has to be sedated. The patient has to be paralyzed. The patient has to be propped up. The nasogastric tube has to be functioning. And these are the very simple things which makes a lot of difference to a surgeon care, right? And of course, if your patient is coughing and bucking, don't expect your pressures are going to be okay, right? And if the surgeon is in a rush, why don't you plan for the extubation? Say them with politeness, the patient is not ready. I'm sorry, it's a trauma conference, I understand, but you need to understand the holistic aspect of intra-abdominal hypertension or leading to abdominal compartment syndrome. Thank you, Dr. Amit. Thank you, Varun.
Thank you, Dr. Manish. So next case was a 34-year-old male who was again a two-wheeler rider with a helmet put on, but he hit the divider at a high speed. His time of arrival was only 30 minutes. His airway was threatened, he was gasping, C-spine was stabilized immediately, he was intubated and put on mechanical ventilation. CCT was negative, air entry was bilaterally equal, systolic blood pressure was again only 80 millimeters of mercury with tachycardia. Fast was positive, 1 liter crystalloid bolus was given, and fortunately this time the patient was a responder. His BP came up to 104/88, heart rate also settled down to some extent. Injection tranexamic acid 1 gram was given stat. GCS was even VT-M5 under sedation, but pupils were bilaterally reactive. Hypothermia prevention was initiated. Including bedside adjuncts, we did a chest X-ray which did not reveal any significant injury. Pelvis X-ray was also acceptable. His fast was again positive in hepatorenal and splenorenal pouches. The question goes to Dr. Hamidi sir. Now again we have a fast positive patient with blood both in hepatorenal and splenorenal areas. What should be done for this patient?
I think I will take him. He's fast positive and he's hemodynamically unstable. We'll take him for emergency laparotomy and control the hemostasis, then find out the injury and they correct the injury.
Dr. Amit Gupta sir, any difference of thought here?
I think he's a fast positive patient, but he has responded to fluid challenge. So probably he comes into the category of responder. I would keep him for about 5 to 10 minutes in the ER, see whether he's still stable or not, and probably would like to get more information about, so his lactates are 4.7, obviously class 3 to class 4 hemorrhagic shock. He's bled significantly, but probably his bleeding has stopped because he has responded to fluid challenge. So I would like to know from where he's bleeding in the belly and get some more information. So ongoing blood, probably this is the case where somebody would accompany him to the CT scanner and probably get a CCT of the torso done so that I know that whether I have to go inside or I can manage him non-operatively and things like that.
So though the first blood gases showed metabolic acidosis, repeat blood gases after resuscitation showed a lot of improvement. pH also improved, lactate levels reduced, hemoglobin was stable. So he was a good responder to the damage control resuscitation, and that is why after hemodynamic stabilization, he was taken to the CT room. CCT abdomen showed grade 4 splenic injury with hemoperitoneum, but no active contrast extravasation. So the plan was NOM because he was a responder and there was no contrast extravasation at the time of CCT abdomen. Patient was managed with non-operative approach. He was successfully extubated on day 2 and uneventfully discharged with satisfactory recovery on day 6. So nobody can overemphasize the role of NOMs in trauma management when choosing the patients correctly and wisely. The take-home message with this case is that not all injuries need a blade, and NOM can be as successful as an algorithm for solid organ injuries as a damage control laparotomy is, but a vigilant watch is what is needed. So if you have a good critical care support, NOMs can be as useful.
Can I add something? Dr. Parul very wisely said, intensive care plays a very important role at this stage. If you see the patient is just having a lactate of 4.7, it's not so high, but the acidemia is too severe. So many of the time, just please don't see the bicarbonate or the base excess. Please also see the gases, CO2 as well. So if your patient is on mechanical ventilation, please try to optimize the ventilation settings. Many of the time, the people believe the rate 16, 18 is good for the patient, right? You have to tailor-make the ventilation setting as per the derange physiology which you are seeing bedside. So that should be the message. So I think, what was the CO2 here, Dr. Parul, in that ABG? Because I saw the AVG and you said 4.7. I cannot
It
read.
it was 46 in the
Yeah,
beginning.
so 46
Yes.
is high. That's what I'm saying. Although I'm not able to see, but I can tell you bang on, yes, it is going to be high. So it's not 46 which you're supposed to keep for the patient with the GCS of whatever it was there, right? So you have to, maybe some elective hyperventilation has to be given for, as a compensation mechanism for the metabolic acidemia. That's it. Thank you.
So quickly we'll skip one case and jump on to the last case because time is running short. This was a 16-year-old male who was sitting on the front passenger seat in a four-wheeler with seat belt on, fortunately, but unfortunately his car rammed into a tree. His time of arrival was approximately after 5 hours of surgery because initially he was taken to a close-by hospital by the bystanders. There he arrived in gasping state. The reaching time there was also around 1 hour after the injury. He was immediately intubated there. Vitals, SpO2 and GCS could not be made out because it was not properly documented in his papers from the previous hospital. CT head and chest was done in that hospital, which showed occipital contusion in his CT head, sternum fracture, bilateral lung injury with right pneumothorax and mild pericardial fluid. He was referred to a higher center due to lack of specialty care from that hospital, and that is how he came to our ER. In the ER in primary survey, he was received intubated with good C-spine stabilization. He was on mechanical ventilation with good SpO2 levels. CCT was negative. Bilateral air entry was good and equal with the right ICD in C2. Systolic BP was good, heart rate was 114, but fast was positive, and pericardial fluid could also be seen with E-fast. GCS was under sedation, so could not be assessed, and hypothermia prevention was initiated. We did a bedside chest X-ray, which showed mediastinal widening, if it can be made out here. Blood gases showed again metabolic acidosis, high lactate levels, high base deficit, hemoglobin levels of 9.9. Again, damage control resuscitation was done. Massive hemorrhage protocol was initiated. The question goes to Dr. Sandeep. How will you approach to this patient who has come to you after 5 hours of injury in shock with metabolic acidosis?
So this patient who has come after 5 hours has already been receiving some resuscitation, maybe partial at a time. So when the patient comes to the ED, you have to re-evaluate your patient. Re-evaluate first since the patient come intubated from outside. The first thing I will do is I have to check whether tube is in position or not, whether the tube is displaced or not. Once the airway is clear, the tube is in place. If you look at the breathing part, chest tube was already in place. Still the patient was in shock. So again recheck whether the pneumothorax has been drained completely or the tube has been displaced. Third part, coming to the circulation part, the fast was already positive and the patient was bleeding. So this was the source why the patient is bleeding. So you have to do a repeat fast maybe. If it shows that there is a pericardial fluid and the patient still remains in the shock, that is a possible source of hemorrhage. Obviously, you have to rule out other sources in the abdomen, in the pelvis and the long bones. So in this case, it apparently has a more problem in the heart. So this patient requires some kind of operative interventions. So immediately I would have to arrange my passive transfusion protocols. I would call my cardiac surgeon or a trauma surgeon or a trauma team because this patient will certainly require some operative intervention. In the presence of a sternal fracture, this becomes very clear that the patient got a cardiac injury and this cardiac injury has to be taken care of by a trained surgeon who can operate on this patient.
So as evident with this blood gas, which was done after initial damage control resuscitation, he was a non-responder. So trauma CT was done because he was not responding to massive hemorrhage protocol. He had blood in pericardium. He was fast positive also. Trauma CT showed comminuted fracture of manubrium sterni with large anterior mediastinal hematoma. And there was active contrast extravasation from internal mammary artery, though there was no suspicion of cardiac injury as suggested by trauma CT. There were multiple bilateral lung lacerations and also there was grade 2 liver injury. So the patient was shifted to the ICU for further stabilization. Bedside echo was called to quantify if there was any increase in the pericardial fluid because he was not responding to fluid resuscitation. After a short period of stabilization, he started going back in shock again. A bedside echo was done, fluid collection was moderate, and in keeping in mind the IMA contrast extravasation and ruling out cardiac injury as suggested by the trauma CT, we planned to do a guarded pericardiocentesis because cardiac tamponade was the first thing which was coming to our mind. A bedside IVC evaluation showed full IVC. Therefore, there was no deficit in fluid resuscitation clearly evident from full IVC. But yes, cardiac tamponade could have been a limiting factor here, which was the cause of unexplained shock here. Please run the video. So, interventional radiologist was called for guarded pericardiocentesis of this patient, keeping the cath lab ready for angioembolization of internal mammary artery and OT ready for emergency thoracotomy just in case the patient crashed after the pericardiocentesis. Unfortunately, during pericardiocentesis, we did not see any benefit of drainage of blood, and unfortunately, patient had further worsening of the shock. Now, cancelling the plan for IMA angioembolization, we took the patient straight to OR and over to Dr. Shefali again for the unexpected findings in the OT in this patient.
I can see Amit sir a little bit frustrated with this case. It's not as simple as it seems, sir. It was not, I mean, it wasn't a classic non-responder, I would say. The patient presented with a BP, like a map of at least 90 and a heart rate of 114. Like, I wouldn't call him a non-responder, I wouldn't call him a responder, I'm sorry. I know this is not the official terms, but that's what it was. It was a confusing case. So what we did was, we had a clear-cut source, IMA extravasation. We prepared the patient for angioembolization, but we could see that the patient is going in obstructive shock. And me personally, I was very well aware this could very well turn out to be a cardiac injury. I was aware the moment you drain some blood, this patient would crash. So we just kept all facets ready, that if time allows, we will go ahead with angioembolization. If time doesn't allow, the OR is ready, everything is ready, we will shift to OR ASAP. Because he was a young guy, the only child in a family. There are a lot of factors to, you can't just tell the father, ki, see, I have some suspicion without any evidence and I want to open the chest. Clamshell is quite a morbid surgery. So yeah, we did do a guarded drainage. Patient crashed, obviously that is a definitive sign of cardiac injury. He was immediately shifted to OR. There was a big mediastinal hematoma. The pericardium was taut with blood. There was a right atrium rent of about 1.5 centimeter just at the junction with SVC, which was repaired with Proline. And there was no other obvious source of bleeding. IMA was ligated. There was no active bleeding. And yeah, then the patient was shifted back to Parul ma'am for further resuscitation.
So one more point which I would like to add here, that because we did a trauma CT and later on when we retrospectively discussed with the radiology team, they also suggested that if there was a suspected cardiac injury, if this suspicion was so strong, we should have gone for a cardiac gated CT scan, which is a better modality to detect cardiac injuries. But because the patient was hemodynamically more or less stable, pericardial fluid was also not very alarming, and there was another source of bleed in the anterior mediastinal hematoma in the form of bleeding internal mammary artery. That's why this is what was done. Patient had a long ICU stay. There was a mutilating, I'll call it mutilating clamshell incision on a young boy, 17 years old only. So pain management was also the priority here. He unfortunately had XDR Acinetobacter infection, and we involved microbiologist, tailored his antibiotic treatment. Unfortunately, when his sedation was discontinued, he did not show any response to any kind of stimuli. We did not know what happened in the primary center where he was taken immediately after the injury. So we went for an MRI to look for any hypoxic brain damage, which might have happened at the time of arrival in the previous ER. And yes, unfortunately, again, his MRI was suggestive of global hypoxemic injury. And we, as a team, we were shattered at that point of time that all efforts gone in vain. And now we are going to have a vegetative patient who his parents would not know what to do with him for the rest of his life. But this patient also came out to be a true fighter. Next day, he opened his eyes. Next evening, he became M6, and he also went back walking home with almost near complete neurological recovery. So the take-home message is trauma is as dynamic as medicine can get, and nothing can be actually taken as black and white. There are gray zones always in every case. Anything that our panelists would like to add?
Let's go back to the three things I said. One is patient factor. The patient is young.
Yes.
Second is injury factor. And the third is resource, where you are. You have everything available. So you can then put your money there. Otherwise, if you have a smaller center, non-availability of a cardiac surgeon, non-availability of interventional radiologist, sorry.
So that's why the accountability becomes higher, because we were here, the referral center. The patient was referred from a primary center to us. It was sole responsibility of our team to do something good for this patient whose parents were now expecting some miracles out of us.
I think congratulations, you did deliver a miracle, Shefali. Big round of applause for Shefali and Parul and all the team who managed this particular patient. It's just that I can agree, you were saying that I was getting crunchy and I was getting frustrated by seeing why you were waiting. But I can understand the guarding, you were, sort of your mental state of guarding. There was a source of bleeding, but not complete bleeding. There was a suspicion of cardiac injury, but not completely. So I can agree your dilemma in taking a decision for a clamshell. But believe it, what saved him was a clamshell only. And sooner or later, I would say that it would have unfolded as it did if there was a cardiac injury. So there were two aspects to it. If there was no cardiac injury, and he survived because there was an atrial injury. If there would have been a ventricular injury, the cardiac tamponade would have been much earlier, and probably you would have opened him up much before than what time it took for you to take a decision. But there was definitely an EMA bleed, and EMA bleeds would not subside on their own, believe it or not. EMA would keep on bleeding. There was a large anterior mediastinal hematoma which would have expanded gradually and then again pressed the anterior mediastinum, causing further cardiac tamponade, even if there was no cardiac injury per se. So I think decision had to be taken. I agree that you took your time, you were guarded, you did a pericardial tamponade and all that. I think it's very well justified. I'm not saying anything about it. But finally, if you find, and this is just a message for everybody, that the heart injuries cannot wait for a cardiac surgeon. This is as simple as that. A trained trauma surgeon or any surgeon who's trained in opening up the chest has to control the hemorrhage from wherever it is, whether it is aorta, whether it is heart, or anywhere else. So many times we have seen, and we've seen it when we were residents, cardiac injuries would just die because cardiac surgeons wouldn't have time. They would depend upon non-beating heart surgeries like putting a patient on bypass. And putting a patient on bypass itself is a lengthy process, 1 to 2 hours, and the patient would die before that. So I think hemorrhage control from wherever is the buzzword, whether it is chest, whether it is heart, whether it is anywhere else. You did a very right thing by opening the chest and closing. It just takes 2 stitches to suture the heart, even a beating heart. And you know that we've had a series of more than 150 patients now, cardiac patients, no cardiac surgeon involved. So just a message for everybody that a dying patient needs hemorrhage control, nothing else. Whether it is cardiac surgeon you can get hold of, whether it's a trained trauma surgeon or a general surgeon who can open up the chest and just stop the hemorrhage, that's it. But a very well done job by the critical care people also, I must say that.
Thank you.
Can I add, do we have minutes? Okay, thank you. On the basis of the case which we have given, It's not a pure case of a cardiac injury because I am from intensive care, so it's also need to be understood there is a significant acute lung injury, which seems to be like overlooked. Now these are very important cases. The reason why, because they should receive lung protective mechanical ventilation strategy. The reason I'm reiterating and reinforcing it, because your patient had a bad GCS later on. And that, you need to understand, the primary brain injury is something which you cannot avoid. But the secondary brain injury, two factors, hypoxia and hypotension. I would have been much more happier, in case if these kind of cases, you portray the PaO2 by FiO2 ratio for them, which is the modern way of evaluation that how much lung shunting is happening in the cases of trauma. So this is the way put them, PaO2 by FiO2 ratio less than 300, less than 200, or less than 100. Depending upon that severity, you can take a call. And it's very important to put them, in your regular serial assessment, which I'm sure it must have been done by Dr. Parul. The second thing.
I assure you, there is nobody more diligent than Dr.
I completely agree.
Following lung
I
protective
completely agree,
ventilation.
Dr. Shefali. I'm just, because a lot of people, they need to know that this is an important part for them. Second thing, I don't know the answer before, I will share something, and maybe Dr. Subodh is also there, Dr. Amit, senior people are also there. The cases which looks so tricky to open up, now there is a situation when we do proceed these cases over extracorporeal therapies. I don't know whether this is a right case for veno-arterial ECMO, but because we had an opportunity to do one eCPR, which means we did emergency CPR for a given one patient, where we know this patient is going to die because of a cardiogenic shock. Now you know whether to open or not to open, but it's a trivial situation, right? So giving them a temporary extracorporeal support is something which you can consider. I seriously don't know whether this is the right way or not, but just an out-of-box of thinking pattern, because we have started doing it in medical intensive care patients to buy the time. Thank you.
Thank you, Dr. Manish.
Very rightly said, Dr. Manish. I would have agreed if there was a blunt cardiac trauma and the cardiogenic shock was due to the blunt cardiac trauma. That means there was no anatomical rent in the heart. Then definitely ECMO, veno-venous or veno-arterial would have been a perfect temporizing measure till the time he recovers. But with a rent in the heart, yeah.
It's not just because of the rent in the heart. So when you do the patient on veno-arterial ECMO, it's also take care of your oxygenation. I seriously, in a patient who has been having the motor deficit from 6 to 1, this is something which we cannot overlook. So that is what, my intention is.
And then probably roll the patient into
But patient was regularly being screened for adequate ventilation, and he did not show any sign of hypoxia as far as blood gas parameters were concerned at any stage. He had bilateral lung contusions, which were very nicely managed with chest physiotherapy and other measures, and lung protective ventilatory strategies were obviously followed in this patient also, as we do as a protocol in trauma patients.
Thank you, Dr.
I would just like to share one thing. When Yatharth started, so I was always searching around. I was managing the entire thing. One night I got a call from the ER that one stab wound has come in the epigastrium. It was around 2 a.m. in the morning, so I went to the hospital. So there was no ultrasonologist, so we did it ourselves. Then analysis kholte hain isko. So I opened up a midline. There was no peritoneum. Then there was blood in his pericardium. So I called. There was an on-call thoracic surgeon at that time, but he was in Gurgaon. He said, I will take 3 hours to reach. And the patient was crashing. So I opened his sternum, opened his pericardium. There was a small rent in his right ventricle. So I have never done any cardiac surgery before. So with the Proline, I just closed that punctured wound, the breathing stopped, the BP stabilized. Then after 2 hours, that cardiac surgeon came and he helped me in closing the wound, and the patient walked home after 7 days. And at that time, we have nothing in the hospital. So it was, if you have to innovate yourself while doing any surgery, right?
I would like to thank all the panelists for being here and giving us valuable insights on different aspects of trauma management. And believe me, happiness is always working together to achieve a shared goal. It is never a one-person game, it is always a teamwork.
So where are the cookies?
Dr. Shefali, where is this cookie jar?
Thank you, Dr. Farah. Dr. Parul, I would now request Dr. Farah to please step in and felicitate the panelists. A huge round of applause for Dr. Farah. Also for panelists, but Dr. Farah too. Thank you so much. From hands-on trauma to high-tech diagnostics, our next session dives into the unparalleled power of imaging, the topic Scan to Survive, the Power of Trauma CT Protocol. Our distinguished speaker is Dr. Atin Kumar, Professor of Radiology, JP and Apex Trauma Center, AIIMS, New Delhi. Professor Dr. Atin Kumar is a renowned radiologist with 286 research publications, 33 book chapters, and over 240 invited lectures nationally and internationally. An international scholar, 2014, of the Society for Interventional Radiology, he has received multiple honors, including the Sir J.C. Bose Oration, 2017, N.G. Gadekar Oration, 2018, and the V.P. Lakhanpal Gold Medal 2011. A fellow of the Indian College of Radiology and Imaging, he also served as the president of Delhi IRIA from 2020 to 2021. I would also request Dr. Ashok, the following chairpersons: Dr. Ashok Kumar Sharma, Vice Chancellor, Senior Professor, Radiology, Maharishi Markandeshwar University. Dr. Ashok is a renowned radiologist with over 25 years of expertise in neuro, cardiac, and gastroradiology, and a distinguished alumnus of IGMC Shimla. Dr. Shekhar Kalia, consultant, interventional radiology, Fortis. Let's welcome our radiology experts to explore how timely and precise image can profoundly save lives.
Thank you so much. We're already running short of time, so without further delay, I would start this session. So we'll go into a different direction now. You've been all studying and discussing and debating the clinical aspects of what to do with a patient who presents with trauma. I will take into how the diagnostics, specifically radiologist and radiological images, can play a role in the clinical management of that particular patient who presents with trauma. So the objective of my talk is, after the end of this talk, you should be able to know when to image. If you've decided to image, then how to image. If you've imaged the patient, then how to look at those images to get a meaningful interpretation, and the findings which you're seeing, the significance of those findings, not just for writing down the report of that patient, but in terms of what those findings are having an impact on the clinical outcome and the management of that particular patient. So ATLS, we all know, starts with a primary survey, secondary survey. I think you've been discussing this and practicing this day in, day out. But the important point which I want to tell you is, as a primary survey adjunct itself, the imaging comes into the picture, and you do a chest X-ray and a pelvic X-ray along with what is known as extended fast in that primary survey itself to look at what's happening to the patient. So with these X-rays, what you do, it's not just that you diagnose everything which is possible, but at least you get an idea what is significantly wrong, if there's a significant pneumothorax, if there is a significant hemothorax, if there is a significant mediastinal shift, or if there is significant emphysema with air leak, or if there is what looks like a bowel segment going into the chest, you know that you're dealing with a diaphragmatic injury. These are ones which you know is something which requires an emergent intervention at that point of time without even waiting for a further investigation, radiological investigation which needs to be done. Combine this with a clinical acumen of clinical findings, you can do at least a ICD or intubation then and there itself to take care of these. Similarly, a pelvic radiograph is done because we know that this is one area which causes a significant impact on the outcome of a patient. And if you pick up a significant pelvic injury, you will know that the source of hematoma is a pelvic injury and you can treat it accordingly. So those can be significant anterior-posterior type of a pelvic APC type of a compression injuries with opening up, or significant injuries in which there can be a significant hypotension, the shock with the patient would be having. And in certain scenarios, you know if it is a bleeding pelvis, and if it is not the venous bleeding, arterial bleeding, either what we have discussed, external fixation or even emergency surgery to take care of the iliacs. But if you have a good IR support, interventional radiological support available and present at that particular time, you can actually go ahead and do a internal iliac artery embolization, which we have done a reasonable number of patients at our institute if and when required. Talking about E-FAST, which is done, you should be very clear about this. It is an ultrasound examination, but with a specific goal. It is targeted, it is rapid and bedside, with a specific goal to look for fluid in the pericardial cavity, fluid in the peritoneal cavity, or fluid in the pleural cavity. Nothing less, nothing more. And you should know the significance of detection of this fluid, because this is going to tell you that these are the likely sites in which the patient is bleeding. So if you see hemoperitoneum, it indicates that there is an organ injury. Could be a hollow viscous injury, could be a solid organ injury, but there is an injury which is going on and it requires further evaluation. What further evaluation depends upon the clinical status of the patient. If the patient is clinically hemodynamically stable, you can subject him to a definitive investigation, which is a CT scan. But if not stable, at least you are taking into the OR, you know which area to target. That's the role for ultrasound. Remember, we do not use ultrasound to look and characterize for the organ injuries. We may be able to see the injuries. We can sometimes characterize the injuries, but what you're gonna miss will give you a false sense of security, will give you a false information that nothing is wrong with that. And for those significant number of false negative scans, we do not want to use ultrasound, because for solid organs, for liver, spleen, up to 50% of injuries can be missed on ultrasound. If you go to kidney, even 60-70% of injuries can be missed on ultrasound. And if you talk about pancreas, and if you of course talk about bowel, almost 90 to 100% of injuries are going to be missed on ultrasound. So you do not want to use ultrasound for picking up specific organ injuries. Then when you want to see what further investigations can be done, then the first step is whether the patient's clinical condition after the initial resuscitation allows for a further imaging or not. So whether the patient is hemodynamically unstable or stable. Only in a stable patient, you will go to secondary adjuncts, which is the secondary imaging which is required. So in an unstable patient, there is almost no role for a CT scan, right? You've done what you could do at the bedside itself, which is chest X-ray, pelvic X-ray, e-fast, and then you take a decision on, in the OR, what are you going to open up in terms of chest or abdomen or pelvis, or whether you're going to open up the retroperitoneum or not. But if it is a stable patient, then the protocol changes. You have the time to subject the patient to a definitive investigation, which is a CT scan. So once the patient is stable enough to be shifted to the radiology department, ideally the radiology department should be as close to the ER as possible in terms of at least the X-ray unit, the ultrasound unit, as well as a CT scan, right? That should be as close as possible. So what are the indications? There are clearly defined indications. Any patient who has a suspected head injury on a clinical examination, the primary and the secondary survey, would require a head CT scan because that is the definitive modality. No more radiographs of the skull required. Those were old generation times. Only thing is which is indicated is a CT scan of the head, a plain CT scan of the head, and it is dependent upon the GCS status of the patient. When you're suspecting a minor head injury, then there are certain specific criteria in terms of loss of unconsciousness and all, which I'm not going to detail, but if those criteria are met, the patient requires a head CT scan. What about cervical spine? Because you need clearance for cervical spine. So there are two different criteria, Nexus criteria and Canadian C-spine group criteria, which based on either of the two which your center follows, if one of these are followed, then the patient requires a cervical spine imaging also. And similarly, there are similar criteria for a DL spine also. If one of these are followed, then the patient requires imaging for DL spine. So if there is an indication for imaging, then what is the modality you do? Again, there is no role for a cervical spine radiograph or even a dorsolateral spine radiograph in a trauma patient. So if there is an indication, then the only imaging modality which you should subject the patient to is a CT scan. Because X-ray, if you do, can pick up some findings, but it will miss also some findings, and you will false negatively clear the spine if you do not see any negative finding in that, and that can lead to a more catastrophic than picking up the injury. So if required, always go ahead and do a CT scan. So for in our scenario, in our trauma center, if any patient is showing a clinical indication for a head CT is done along with cervical spine. Both are done as one investigation together to clear that patient for head and cervical spine. Coming to torso trauma, I've told you the unstable patient, but if the patient is stable, either stable to start with or gets stabilized after your initial stabilization and resuscitation, then this patient would be subjected to the definitive modality, which is a CT scan. So what type of a CT scan? It is a contrast enhanced CT scan. And I'll go into the detailed protocol of a CT scan. But what is the aim of doing a CT scan? You want to pick up injuries, you want to characterize injuries, and you want to pick up specifically those injuries which are management changing injuries. The first and foremost goal in a stable patient is to have predominantly a non-operative management, right? If the patient remains stable, but there are still, after CT scan, there will be some findings which would indicate, even in a stable patient, that the management should be changed to maybe at least an interventional radiology, or if not, then a OR management. And as a radiologist, you should be able to pick up those injuries and not miss them in terms of that. And let's see what are those. There will be a tweak in protocol if you are suspecting a urogenital injury. So if the patient has hematuria, then you also want to look at the entire urinary tract to look for the cause of the hematuria, which can include right from the urethra. So if there is a urethral injury which is suspected based on the clinical findings, you may sometimes require to do a retrograde urethrogram first before you put in a Foley's catheter. Or if the Foley's is done clear and there is still hematuria, the CT protocol would require a tweak to evaluate a detailed evaluation of the kidney or the urinary bladder as the case would be. So what is the CT protocol would you follow? This is done when you have taken a decision that the patient requires a CT scan for a definitive evaluation. First foremost, there is no role for non-contrast CT scan, right? So once the patient is sent, we will do only a contrast enhanced CT scan. And if I'm talking about now a torso, when we do torso, we include chest and abdomen together as one entity. We do not do either only a chest CT or only abdomen CT. In all scenarios, chest is combined with abdomen with a very few limited exceptions. I'll just like to point out one exception. If it is a single isolated penetrating injury in the abdomen, lower abdomen, you may not want to include a chest. Or if it is a single isolated penetrating injury above the level of nipple, you may just want to do only a chest and not abdomen. Besides that, there is no indication for doing either only chest or abdomen. It is one complete torso scan. So that's a decision which you have taken. Second is, there is no indication to give a positive oral contrast. For routine CTs, we have been giving positive oral contrast for last 20 years, but for a trauma CT, we do not. Two reasons. It has been shown conclusively positive oral contrast does not aid in findings which are specifically related to trauma. Secondly, it will delay the CT by at least 45 minutes because that is a time required for you to give a good amount of oral contrast. So do not use a positive oral contrast. Third thing is, we do not rely on a previous report of a normal KFT before we want to give contrast. Time is essence in this particular scenario, and mostly it is young patients, and we go ahead and we presume that the kidneys are normal, and we go ahead and do a CT scan. These are actually established guidelines which I am talking about, so we do not want to wait for a KFT. Even if, let's assume there is a chance of AKI, the patient was in AKI, or a CT contrast will lead to a AKI, that we can handle later on, but what's more life-threatening is the amount of trauma, the golden hour which you do not want to miss, or the early hours, and you can actually go ahead and give a contrast. There may be a specific scenarios in which you would want to give a positive contrast in the bowel, specifically perrectally, and those specific scenarios I can show you example, but that is decision which is taken specifically if it is a penetrating injury or a perineal injury when you are suspecting a rectal injury. In those, after the first protocol is done, you can add upon a rectal positive contrast and then repeat that particular designated small focused area CT again. What we want to do is not to miss any injury. Significant injuries are vascular injury. So for that, if you have a good arterial phase contrast CT scan which is done, you are likely to be able to pick up arterial injuries even better. So we want to do a dual phase injury, because if you do an arterial phase, that picks up vascular injury better but does not pick up parenchymal injury as good. But if you want to do a venous or a delayed phase, it misses out on some amounts of arterial injury but shows the organ injury better. So you want to have two phases. Why not do two phases in each and every patient? Because it is double the amount of radiation which you are giving to the patient. So we would want to do a dual phase CT, arterial and venous, in patients in which we have a higher suspicion of any significant vascular injury. And we want to tweak a protocol for doing a delayed excretory phase, specifically when we want to look for a renal pelvic ileal system injury, or we want to evaluate the bladder. If we are suspecting bladder injury, we want to do a CT cystogram. In certain scenarios, we may just do a single phase CT, which is a venous phase. That means we want to avoid extra radiation. This we will do only when we are not highly suspecting a significant vascular injury, in which the amount of trauma is low. CT is being done more for like a screening or a rule-out modality than to look specifically for injuries, or especially if it is a child at our institution, if it is a pregnant lady. In that case, we want to do a single phase just to reduce down on the radiation. It's not that the venous phase will not pick up major vascular injuries. It can. A good astute radiologist can pick up those injuries even on a venous phase, but it gets slightly more difficult to pick them on a venous phase. What is the aim of doing is all this imaging? You want to look for organ injuries. You want to pick up the morphology of injury. You want to pick up ultimately give the organ injury scale as given by the AAST. But you want to look specifically for those injuries which change the management. One of those injuries is to pick up acute bleeding, active bleeding, which is going on at that particular point of time, which is characterized by two different things. It is either a contained vascular injury or an uncontained vascular injury. In radiological terms, we call it as a active contrast extravasation, which is an uncontained injury, vis-a-vis a contained injury, which is a pseudoaneurysm formation. So there is a vascular injury, but it is led on to a pseudoaneurysm formation, which is a potential to rupture and lead on to a catastrophic hemorrhage subsequently. How do you differentiate it radiologically? You see on contrast CT, you see what looks like a vascular contrast. There is contrast, but it is not confined to the shape of a normal expected anatomical vessel at that particular site. And if you do a delayed image, this is the arterial phase, this is the venous phase, you see this is spreading out. That means the IV contrast which you have given is going out of the vessel and spreading out into either the parenchyma or into the peritoneum, and this tells you that the patient is actively bleeding from a big arterial source at the time when he's undergoing a CT scan right on the CT table. So even if he was stabilized at this time when he was being shifted to CT, he can potentially get unstable very soon, right? And the second scenario is when you do see a vascular injury, but it is more rounded, and if you do a delayed phase, you do a coronal reconstruction, you see it remains rounded in multiple phases, and you do a good quality reconstruction, you can see this round bubble. This is the pseudoaneurysm. So it's not actively bleeding, but you know the source of bleed is the pseudoaneurysm. It is intermittently bleeding based on when his BP shoots up, it bleeds. When it bleeds, the BP comes down, there is a spasm which is occurring, the pseudoaneurysm goes into spasm and stops bleeding. But it requires ultimately some form of intervention in more or less every case. When you see a lot of contrast extravasation, even in the peritoneum, we are sometimes called in as an interventional radiologist to even manage these patients. Angiogram done in the same patient shows the right hepatic artery is completely ruptured, there is free bleed in the liver, and this was embolized, and this patient luckily was survived after that. Sometimes, just to show you an example of how dual phases can help, this is the arterial phase, this is the venous phase of the same patient. You can see that you can see a large pseudoaneurysm in the arterial phase, but if you had just taken this phase itself, almost nothing was seen. It appeared the spleen was almost normal. So this injury can be missed if only a single venous phase is taken. This patient was subjected to a DSA, which showed that there was not just a pseudoaneurysm, but it was bleeding also, and this was coil embolized. Okay, another example in which you can have a good quality protocol helping you. If you see this mediastinal widening right at the chest X-ray itself, you know that you want to have a good arterial phase to look for subtle injuries of the aorta. It is very, very required, and you have to have a good suspicion for looking at small injuries of the aorta. In this case, this was the cause of the superior mediastinal widening, a large hematoma due to aortic dissecting pseudoaneurysm right at the level of the isthmus. This is the most common site. 95% of the site times the aorta gets injured at this point, and good, beautiful recons give you those images. So it's not just the acquisition protocol, the post-processing, first the detection on the CT scan, and then post-processing to show you what is the extent of the injury helps you to plan even your intervention or the surgery even better, right? Coming to another tweak in the protocol, when we are thinking in terms of a hematuria, I told you there are specific indications to get a retrograde urethrogram done, and in this case, a retrograde urethrogram was done, and this is a stretched posterior urethra, but not freely injured. But in this case, there is a posterior urethral injury, there is a contrast excision. In these cases, of course, if the catheter cannot be passed through, you will require a suprapubic cystostomy in these scenarios. Sometimes hematuria cause is not urethra, it is either kidney or bladder. Like in this particular case, you can see a transaction through the kidney, lower pole of the kidney. In these particular scenarios, we want to include a excretory phase. After 7, 8, 10 minutes, when the kidney starts to excrete the IV contrast which was given, and you see a significant amount of contrast which is extravasating out right at the region of the lower polar calyx and the pelvis along the ureter, you know these require intervention in forms of either a DJ stent or a decompressive PCN to take care of this pelvic urethral system injury. Another example, I'll show you this example to show that we were having fluid in the peritoneal cavity, but the patient was having hematuria. When the patient has hematuria, you do not find a cause in the kidney, you do not find a cause in the bladder or in the urethra, you need to evaluate the urinary bladder. In this case, there is only just fluid all in the peritoneal cavity, and when we did a CT cystogram, which is done by installation of positive contrast through a IV cannula into the bladder, there is a intraperitoneal rupture of the bladder which is seen. Is this important? Very important, because intraperitoneal bladder ruptures require a operative repair. You cannot manage them by just a Foley's catheter. But sometimes it could be extraperitoneal rupture as a cause of the hematuria. These can be managed with just a urinary catheter in situ. Another example, in this case, a Foley's catheter was placed. The patient was draining urine through the Foley's catheter. But when the CT was done, you could see that the Foley's catheter is actually malpositioned. It is only in the posterior urethra. It is not going into the urinary bladder. Maybe there was a partial communication from the bladder, but there is a posterior urethral injury which is seen only on the CT scan, and when you give contrast, you can see there is extravasation here, and there is also bladder neck injury which was diagnosed. So this would also require a definitive operative repair. Another area in which you want to manage and tweak your protocol is when you're thinking in terms of a pancreatic injury. CT is a good modality to detect early pancreatic injury. However, if you are having a doubt on CT scan whether the main pancreatic duct is involved or not, because that is the main management changing decision in pancreatic injury, we sometimes subject the patient to a MR to better characterize, to look at the duct, and in this particular case, the MR was showing a laceration which is involving the duct. Another example, hypotensuria in the pancreas. When we did a MR, we could see a full thickness laceration, better than what it was visualized on the CT scan, and a MRCP image showed a complete disruption of the main pancreatic duct. It significantly upgrades the injury to at least a grade 4 pancreatic injury, and which may require a distal pancreatectomy depending upon what site of the duct is injured, distal to the confluence or proximal to the confluence depending upon that particular thing. Sometimes you need to change the protocol and give oral contrast also. What are those indications in which you are suspecting a esophageal injury? Like in this particular case, there was significant hematoma around the esophagus, there was air around the esophagus after the initial CT. Then we gave a positive oral contrast and we could see there was a complete esophageal rupture at the lower end. So you have to change your protocols depending upon that particular patient clinical scenario. In this case, there was a suspicion of a rectal fistula or a bladder rectal fistula because there was particulate matter, fecal matter, which was coming out through the Foley's catheter. In this case, we did a CT cystogram and it clearly showed the site of fistula's communication with the bladder. This was a penetrating injury. Again, you should know what investigation to do, what particular tweak in the protocol you can do even after you've done your first protocol, what additional sequences you can do to pick up those injuries which matter a change in the management. This is another example. In this is a penetrating injury reaching close to the colon, but we are not sure whether the colon is involved or not. In this case, we can give a rectal contrast and we can see that there is a leak of rectal contrast. So you can tell that there is definitely a colonic injury and the patients can be operated. Sometimes it's not just the tweak in protocol, but a good quality reconstruction, sitting on the console, looking at the images, coronal, sagittal, axial planes, making reformats, which can help you pick up those injuries which are not seen in the first scroll or only the axial images itself. So this is, I'm showing you a good quality reconstruction. So this you can see, these are coronal reformatted images. This is duodenum. You can, if you see clearly, you can see clearly a big rent in the inferior wall of the duodenum with duodenal contents going out, as if you are seeing a operative image in front of you in the eye. You can recreate these images. I am not recreating it. You can actually show these images by a good quality reconstruction. So it's not just change in protocol, but a good sitting there on the console, making good images helps you to pick up those injuries itself. Okay, this is something, there was a suspicion for a bowel non-enhancing part. You can use special advanced sequences in CT. We have a dual energy CT, which we sometimes use to look at iodine map, and this clearly showed this was an enhancing bowel, this was a non-enhancing bowel, and it was confirmed on operation theatre also. Another example, in this case, we are going to pick up mesenteric injuries. So mesenteric and bowel are one thing which you cannot miss on CT scan. This CT is the only modality which is the most sensitive, and you have to have a keen eye and a strong sense of suspicion to look at mesenteric and bowel injuries, because these are management changing injuries. The number of hours which are spent in delayed hours in picking up these injuries significantly increase the morbidity and mortality. In this case, there was a large mesenteric hematoma which was confirmed on CT, and in this case we could see fluid in the abdomen, bowel looking abnormally enhancing, but we could not pick up any particular mesenteric hematoma per se or a bowel non-enhancing thing. But I knew there is a pneumoperitoneum, so there has to be a mesentery, but a good quality reconstruction of images in the MIP format for vascular injury showed that one of the vessel of the superior mesenteric artery had a dissection and a thrombosis. So this required a operative intervention. Sometimes if it is a penetrating injury, you need to tweak your images to look at along what a trajectory of the path is. So you can see this is not a normal axial image, this is not a corneal image, but this is something which I have made by looking at the trajectory. You know that the trajectory, the penetrating trajectory entered the liver, but this is the entire extent you can predict based on this. Lastly, you have to look at the diaphragmatic injuries too, because diaphragmatic injuries, if you're gonna miss, they may not present at this time, but days down the line, weeks down the line, months down the line, the patient is gonna end up with a hernia, and then you will feel that you've missed up an injury. It is only the radiologist who will pick up these injuries. So this is a diaphragmatic injury here. Small, subtle, this was a penetrating injury, but unless you're looking for it, you're gonna miss it. Last 2-3 slides about peripheral vascular injury. You have to have a suspicion for a vascular injury clinical and change your protocol to also include a CT angiogram for a peripheral vascular trauma, maybe upper limb, lower limb, depending upon the signs which you're seeing. You can have a transected segment, you can have a completely ruptured segment with a large hematoma or a pseudoaneurysm, or you can have a thrombosed segment. We use a lot of CT angio in our head and neck regions also for blunt keratico-vascular vertebral injuries based on if there are skull-based fractures, if there are vertebral fractures in the cervical spine, and we do pick up a lot of injuries. This is a vertebral artery pseudoaneurysm in this particular case, external carotid artery pseudoaneurysm which was embolized, and we can also pick up vertebral injuries. So my take-home message for this talk, sorry I had to rush up because of lack of time, is it is important to have standardized protocols. Like this is one field which is an emergency field. It is not possible for each one of us to be always available every time of. There will be always a rotating pool which comes in. If your center has standardized protocols which you have made after discussion with the radiologist and the clinical team, those protocols are in place, you would know that they would detect most of the injuries in most of the patients if you're following the protocol. That is why the protocols have been made, because they follow that. However, you do need to do additional acquisitions in certain patients, which I've shown you multiple examples, either based on the clinical indication or the imaging findings which you have picked up on those routine protocols, imaging-based protocols. You need to improvise also in certain scenarios. What it means is having standardized protocol does not mean that the radiologist can go for a walk and the technician will take the CT scan, because technician says मेरे को पता है कि क्या करना है, ये चीजें करनी है, सर्जन ने लिख दिया, मैं कर लूँगा, आपको रेडियोलॉजिस्ट की क्या जरूरत है on the console. But if you are sitting there, you would know how to tweak that protocol, what additional thing you can do based on the clinical imaging suspicion you are having, so as to give the complete answer in then and there itself. There is a narrow window when the patient has reached CT scan table. You do not want the patient to go back and then come back again. I additionally want to do this, sir, so please send back again. No, whatever you need to do then and there itself when the patient is there. So on a case-to-case basis, you need to improvise, and you should be, as a radiologist, at least not missing, which I classify as not to be missed injuries, which change the management from a non-operative management to at least some interventional form of a management. Bowel injuries, mesenteric injuries, diaphragmatic injuries, vascular injuries, intraperitoneal bladder injuries, pelvic aerial system injuries, even major aortic injuries. And trauma surgery and radiology work best as a team together. I always talk to my radiologists, say, make good professional friends with trauma surgeon, to the extent, call them as your best friend in the hospital also. If you want to learn and treat the patient with them, Similarly should be the message to you. Trust radiologists, make them friend, because two together can actually make a definitely intervention in the management of the patient. And remember, Rome was not built in a day. All this, what we have shown, we've made mistakes, we've learned from it, we've worked together, we've made protocols over years to reach it, and we are still doing this, and we are changing our protocols as we learn more and life teaches us more and more new. Thank you. Thank you so much.
Thank you, Atin. Very nice talk, and you have covered almost everything.
Thank you, sir.
Only one thing I would like to ask you, and you must be aware, now we have the latest concept of whole body CT scan in the trauma patient, because why this concept has come up, and even the scenario of the emergency department has changed. We should have all the state-of-art equipments in the emergency department. It should be just a walk-in. First of all, we should have a state-of-art ultrasound, then at least 64 slice CT. X-rays are just, they have become rudimentary, but they are important in part of orthopedics only. So in that line of now, the new concept has come up that every trauma center should, whether it is in a district setup or is in a lower hospital, it should have at least a 64 slice CT. So in a one go, we can go in from head to pelvis region. So what is your experience in AIMS regarding this? Because number of studies has come up in even 2025 that it has a definite role in the outcome of the patient.
Right, sir. A very good question, because a lot of data is now there regarding a whole body CT protocol, and it is being followed word over in many centers, especially in the Western centers. The difference between a whole body CT protocol and what we follow is what was my first point was have standardized protocols so that you can do good to most number of the patients, and even if an untrained person is there, in terms of an untrained, or I will not call it untrained, but a less trained fresher trauma surgeon or emergency physician in the room, in the ER, or similarly a radiologist in the radiologist room. If you do this, you would know the standardized protocols that मैंने अपना काम ठीक से कर दिया है. I would probably not be missing something. So a more conservative approach is do a whole body CT. You will not miss anything, right? This is a whole body approach, and this is being followed in centers across also. But what we follow is, why do a whole body if it is not required? Of course, you are gonna pick up one small fracture here, one small injury there, if it may or may not be clinically significant. What we do is, if there is a good clinical evaluation with a primary survey, secondary survey, a detailed secondary survey has been done, only after that the patient is supposed to be shifted to the CT scan, you would know what you are expecting. When you know what you are expecting, the indications for head CT are clear, indications for cervical spine CT are clear, indication for torso is clear, and we do accordingly. So if it is head and cervical spine required, we do a head and cervical spine. If we have an indication for a CT angiogram, we do a CT angiogram. If we have indication for torso, we'll do torso. We may end up doing almost everything what our complete whole body CT protocol says, but we know that we are not blindly doing a whole body CT protocol in most of the patients, because that's what they kind of follow, that evaluation पूरा नहीं है तो कोई बात नहीं, सब करा दो, सब कुछ कर दो, and we'll see what happens. But we do what is required based on the clinical indication and what's likely to the benefit of the patient, rather than exposing every patient to a complete radiation in every case. If in our trauma center, in our busy trauma center, in our 24 hours, we do 90 to 100 CT scans in 24 hours, which includes 25 torso CT scans per 24 hour, rest are head and cervical spine or some peripheral CT scans. If we end up doing a whole body protocol in 100 patients, we will have millions of images, our PACS will bury down, our radiologist will bury down, and we will have not a meaningful, I'm not saying that that is wrong, but we've also learnt it over a period of time that what needs to be done.
So only thing I would like to add, you have explained very nicely. When a patient comes with multiple injuries, in that case, it has a definite role and with a standard protocol. I am just saying arterial, venous phase and delayed phase. It takes not more than because what is the golden time? It is a 1 hour, patient has reached to you 1 hour, there are multiple injuries. So you give 10 minutes to the radiologist, to the radiology department. And you will get from, suppose you have a cranial injury, your head will be covered nicely. If you have your cervical injury, that will also be covered. If you have a chest, that will also be covered. And beauty is the abdomen, because you are doing the contrast study at the same time. So that is the beauty, and I am sure in coming another 5 years, this protocol will overtake, because the question is of the radiation. Radiation doesn't matter to the patient when he is already in a critical stage. So we need the maximum information because it is a multidisciplinary approach. We need all the doctors there. So we need a comprehensive thing how to approach. So that is the role. I report daily almost 10 whole body CT with good contrast studies. It is from the PAC system, and you will be surprised. Sometimes you find injuries in the brain, cervical, even in thorax. Dr. Atin was saying, even aneurysms, they are also seen on those scans because they are very well nicely done, because now we have a high-end scanners and reconstruction is beautiful. So we have the 3 phases just in 10 seconds. And radiologist should be experienced in that case. That is a very important thing. You may miss 5 to 10% thing, that doesn't matter. But at a whole, it will be very beneficial to the patient where there are multiple injuries from head to pelvis. And in majority of cases, even we pick up things from the abdomen also. Abdomen, as he was saying, in intestine, there is a difficulty, definitely. I do agree. Small aneurysm, there is definitely a difficulty.
I'm really sorry to disturb you. I'm sure whole body CT is amazing, but let's stick to the topic. We're running short on time.
So, if you allow me, just I can make a quick comment. Can I make a quick comment? Yes. Okay. So, I want audience to know that Dr. Atin, he is a certified ATLS instructor. He is a radiologist and he is a certified ATLS instructor. This is one. So he understands the trauma in and out, and we have been working in the trauma center for 20 years. This debate is unending, the whole body CT or the select CT scan based on the clinical findings. I went to the Melbourne Alfred Hospital, and they used to do the radio conference like we do twice a week. They do every day. Every patient, they discuss whole body CT, whole body CT, whole body CT. Then after the radio conference, I asked my colleague, Dr. Russell, he is a trauma surgeon there that time. I asked him, why are you doing whole body CT in every patient without any finding? 20 CTs were discussed, finding only in 1 or 2 patients. First he said, it's our protocol, institutional protocol. But we all work in evidence-based, we talk about evidence-based medicine, we talk science, right? We should put our mind before say ki whole body kyun or select kyun nahi. Then I asked him, okay, that's your protocol, but what is the basis of making such a protocol? Yeah, see a lot of MLCs cases, this thing, and see insurance company, and say they ask for, so just to plug all the holes, we do a whole body CT. See, in the world of science, we are talking shit, that to cover the medical legal compensation, insurance, we are doing the whole body CT just second. Second point is, I give you another example. It's a debate about in carcinoma breast, the screening, right, incidence. So there is an argument that there should be a screening to pick up the carcinoma lump early, right? So there is a counter argument that even if you pick up on routine mammography screening a 5 mm tumor of this thing, you don't know the natural course. It will be a florid carcinoma someday or not. Likewise, if you do the whole body CT in 100 patients and you pick up some injury in 2 patients, not necessarily they require that CT, that injury requires your attention. And you are exposing so many patients for the whole body CT. So it's an unending discussion, I think. And she is right.
Yeah,
that
so
we are running short
I'll
of-
also say
yeah,
the same
yeah.
thing. It is not that, it's not that we are missing something. We are going based on our clinical acumen, and whatever is required and indicated, we are doing it.
Sir, we can continue this over tea,
thank you.
coffee. This whole
Thank you.
body
I have,
CT
sir, I have two
Thank you.
questions.
Yeah,
to
yeah,
ask.
please.
It was a great talk, sir. Very nice cases. Sir, I just want to ask you that suppose there's a hemodynamically stable patient and we take a CT and we see some small pseudoaneurysm or some blush. So what is your threshold to take him for any embolization or some surgery, or
Right.
just
It's a
wait
very,
and
very
watch?
nice question, and the answer to which we have also learned over time, right? If you see a pseudoaneurysm, it is a potential to bleed, right? You have to treat it like this. So depends upon the clinical status of the patient. If clinical is stable, right, and the pseudoaneurysm is embedded right within a parenchyma without any significant hematoma over and around it, and no significant hemoperitoneum at that point of time, now over a period of time, we have some pseudoaneurysms we've tried to follow up conservatively over a time. I'm talking about few millimeter size pseudoaneurysms. We are not wanting to chase each and every pseudoaneurysm if we see it. And we've seen that sometimes they actually, because of spasm, they take care of itself. If it persists on a well, let's say a follow-up CT at the time of discharge or a ultrasound, we can follow up them with ultrasound, we might want to do it. But in those other cases, if the size of the pseudoaneurysm is large and or if there is an adjacent hematoma, laceration, and there is a hemoperitoneum, although the patient is stable, we may want to go and do an interventional radiological treatment in that particular pseudoaneurysm. If it is an active bleed, we are more, threshold is slightly lower for going and treating it, especially if it is going into the peritoneum.
So, sir, we take a follow-up CT after how much time?
We want to do a follow-up ultrasound itself. If the pseudoaneurysm, we want to see it on ultrasound. If we can follow it up on ultrasound, pretty good. If not, then we may sometimes repeat a CT at the time of discharge, which is usually at 6-7 days, just to see the symptoms.
Thank you, sir.
Sir, I have very limited things to say because your presentation was so awesome. Those beautiful reconstructions, even as an intensivist, I could make out the areas of concern and the pathologies, and I know the real mind behind it. It's not the whole soul job of the radio technician. The actual ultimate mind is of the radiologist who is sitting behind the console and taking the correct cuts at the correct time so as to be able to do a good reconstruction later on and look for the tiny pathologies which the trauma surgeons obviously can think of later on. So thanks to you for that awesome presentation, sir.
Thank you.
And we were talking about whole body and trauma CTs. So coming from a private hospital, we also used to have a lot of hue and cry in the beginning over the huge bill expenses which were incorporated into the trauma CTs for all the patients who would come with code polytrauma in the ER. But retrospectively, when we looked at the outcome of those CTs, I would still believe in that saying that a stitch in time saves 9. And
Definitely.
it is worth doing it even if we are able to save a few lives out of those long list of patients who underwent trauma CT as a protocol.
Sure,
So
ma'am.
protocols are definitely based on clinical evidence and they should not be questioned. They should be followed for best practices.
Yeah, so I think I was clear enough, but if this message is going wrong that we are avoiding CT, it's not the message. We are doing 90 CTs per 24 hours.
That's
So
a
we're doing
huge
CT which is required in every patient. It's not that we are managing them without a CT scan. We are doing, but we are doing a tailored clinical indication based CT scan. That's what my point.
And
Thank
my
you so
next
much, ma'am.
question might sound stupid, sir, but I couldn't stop asking it. Do we have some postdoctoral course in trauma radiology in India?
One or two places have an emergency radiology fellowship, but that includes entire emergency radiology, not just limited to trauma. We do not have a fellowship in trauma in radiology right now, but with a prior permission, anyone is most welcome to come and do observership. Even if you come in trauma surgery, you will learn radiology. That's what I want to say, because we work as a team together.
Trauma
And
center is
about
the
your
best
data,
place
we
to
all
run
know.
these kind of
We
courses.
all know about the radiology images. It is like anything else. There is significant amount of data available. How to mine that data and what to get interpretation of data, that is same what we are doing. So data is available all around us, actually all around us. Thank you. Thank you so much for it. Thank you, Dr. Shefali.
That was surely a very insightful session by Dr. Atin Kumar. I would now request Dr. Parul Asar, HOD, Critical Care, to come forward for the felicitation. Dr. Atin Kumar. Dr. Ashok Kumar Sharma. Dr. Shekhar Kalia. What an insightful day it has been. On behalf of Yatharth Super Speciality Hospital, we thank each one of you for being the part of this impactful journey. A heartfelt thanks to all our faculty, panelists, coordinators, and attendees. Your passion for trauma care has truly lit up this hall today. We also take this moment to thank our academic partners and guiding mentors for placing their trust in us and for their invaluable support in making this conference a success. To deliver the official vote of thanks, we now invite Dr. Farah Imam, Head of Emergency Department, on stage. Dr. Farah, I request you to be here on stage for this vote of thanks. Please deliver this vote of thanks.
So, good evening, everybody. This is a heartfelt thanks to all of you who have made this conference a success, stayed with us patiently till this time. So, I'm not going to take up that much of time. So, this idea started with Dr. Shefali joining the the hospital. When she joined, this one resident needed to do a trauma CME. So, I requested, why don't we organize one? So it went to a large scale, the first conference. Now this year, we had the courage to arrange it again. And hopefully people have learned a lot from this. And I'll not take much of your time. Thank you to all of you for attending this conference and making it a success and encouraging us to plan further. Thank you.
A special thanks to the Indian Society of Trauma and Acute Care, whose members were present with us from morning till evening. We are very, very grateful that you accepted our request for providing us ages. Thank you so much, STAC.
All the support staff. And our one point of contact, Mr. Kuldeep, we would like to thank him because he helped us throughout. He's been patient with us, and every time we would say, you are our single point of contact for helping us throughout the conference. Dr. Apurva, Mrs. Kaur, Anju sister, Ms. Anju from International Marketing, Divya from Digital Marketing, Ms. Sushmita, all of you have made this conference a success. So thank you very much. Thank you. All the organizers and the marketing team.
With that, we bring this incredibly productive day to close. Please join us for high tea as we continue the conversation, network, and reflect on today's profound learning. Thank you once again, everyone. Until next.
How many residents, just sorry to interrupt you, how many residents still have the strength to go ahead with the trauma quiz? I can give you one incentive. We have a cash prize for the winner. We can do it in-house later. That's okay. If you're willing, I'll go ahead with it. Otherwise, we'll skip it. बताओ।
Thank you once again, everyone. Until next time, let's keep pushing the boundaries of trauma care. Stay safe, stay inspired.
Dr. Sahil Gupta. So he is the whole soul trauma surgeon in Amritsar right now, the sole trauma surgeon. He has come to our conference on his birthday. I would never do that. I would never work so hard on my birthday. So a very, very happy birthday to you, sir. And we have a small cake cutting celebration for you. Please come on stage.